difference between these two, it is going to increase, and definitely in this case also we can see the cyanosis. Examples are hemorrhage, CHF and shock, right? Last type is histotoxic. The name itself will tell you what does it mean. Histamine tissue, if the tissue got toxins or it is gotten intoxicated, so what will happen? There is no problem in the lungs or atmosphere, there is no problem in the oxygenated hemoglobin, so that's why these three will still keep on say normalized. So but if I talk about the CVO2, what will happen? The tissue is you can say the enzyme per se in the tissue, they are affected by the toxin. They are not able to utilize the oxygen. If they are not able to utilize the oxygen and produce the energy, of course there will be no new oxygen which will be coming towards the tissue. Already the old oxygen is not gotten utilized, right? So please remember what will happen on the venous side. Whatever oxygen came on the arterial side, it didn't go to the tissue, it is going to go towards the venous side. So CVO2 is going to increase. Please remember the CaO2 was this and CVO2 normally was this, but now eventually what will happen? The CVO2 is also going to increase. So the difference between these two, it is going to decrease. Please remember, if everywhere oxygenated hemoglobin is there, why there will be cyanosis? There will be no cyanosis, okay? And the examples are cyanide poisoning and beriberi. Let's move on to the periodic breathing. Let's say the person has gone on to the mountains, right? And the atmospheric pressure, as we go on the top, the atmospheric pressure decreases and the content of oxygen is also going to decrease. Please remember, the concentration of the oxygen remains same. It is going to be 21% at sea level. It is going to be 21% at the top of the Mount Everest. But the overall partial pressure has been decreased. So the content of oxygen is going to decrease, right? And because of that, what will happen? The person will suffer from hypoxia. As soon as hypoxia occurs, he is going to stimulate his respiratory centers and start doing hyperventilation. But as soon as he is going to do hyperventilation, two things are going to occur. He's going to take more oxygen inside, but simultaneously he's expiring also with the more force. So please remember, there will be carbon dioxide washout which is going to take place. And because the carbon dioxide is the main stimulus, what will happen? Because of this carbon dioxide washout, again the person will go in the apnea. So there will be hyperventilation followed by apnea. Again, when the apnea is going to take place, there will be more accumulation of carbon dioxide and lesser oxygen that is going to come. So what will happen eventually? Again, the ventilation will increase. So this cycle goes on and on and on unless and until the patient stops breathing. Alright. So please remember, hyperventilation followed by apnea, hyperventilation followed by apnea. That is going to be nothing but kind stroke or chain stroke breathing. Now please remember that whenever this chain stroke breathing or kind stroke breathing, you're going to see a particular pattern. It looks like a diamond shape, or it is also known as crescendo decrescendo pattern. Crescendo decrescendo pattern. Okay, so that is nothing but kind strokes. Physiologically, it can occur when the person is going to go towards the high altitude. Pathologically, it can occur in the sleep apnea and congestive heart failure. Coming to the Biot's breathing, that means Bekar breathing. Please remember B for B. When the Biot's breathing is going to come, that means the brainstem neurons, they are damaged, and brainstem causes tuning of the respiration, right? But the tuning will be lost over here. There will be no tuning whatsoever. So what is going to happen? There will be irregular breathing. There will be very irregular breathing, right? There will be very irregular breathing. Irregular breathing is going to be seen when the bulbar polio occurs. That means brainstem neurons are damaged, plus the meningitis or in the uremia. Then coming to the Kussmaul's breathing, that means the patient looks as if he is hungry for the air. That means the rate of the respiration and the depth of the respiration both has been increased. So rate and depth both has been increased. You can see that in the diabetes ketoacidosis. Now, if I draw the normal respiration over here, it will look something like this. if you see at the rate and depth, both have been increased. So please remember, in the diabetic ketoacidosis, patient looks as if he is hungry for the air, and rate and depth of the respiration, both are going to increase. So that is known as the Kussmaul's breathing. Next, coming to the dysbarism or Casen's disease or decompression sickness syndrome. What is it? When the person is going to go away from the core of the earth, that is on the high mountains, we know that the atmospheric pressure is going to decrease. Vice versa, if the person is going towards the core of the earth, that is nothing but towards the deep sea, what will happen? The barometric pressure near or surrounding him, it is going to increase. Now, when the pressure is going to increase, what will happen? Normally, the nitrogen is not dissolved in our blood. It cannot cross the, you can say, the plasma membrane and go into the tissue. But as soon as the barometric pressure surrounding the deep sea divers, that is going to increase, when they are going to go in the deep sea, definitely this nitrogen is going to get dissolved in the blood. Not only that, it is going to deposit in the multiple tissues such as adipose tissue. Now, yes, the atmospheric pressure is going to increase. The gases which are going to be, normally it is in the gaseous form, they start getting compressed and dissolving into the blood. So dissolved nitrogen will be formed. If the person comes up slowly, steadily, what will happen? Those whatever gases were there which got dissolved, they will come back slowly and steadily into the blood, and from the blood they will come into the alveoli and they will go out. But the problem is that if they ascend quickly, what will happen? The gases won't get proper time and they will start forming the gas bubble into different places. So please remember, if there is a rapid ascent, he went down, but if he rapidly ascend towards the surface of the water, definitely there will be decompression of gases and the bubble formation will occur. And this bubble formation is going to be responsible for the symptoms. What is the symptoms, or what are the symptoms that are going to come? First thing first, they are going to block the capillaries. Why? Because in the blood, you have the bubble formation. That bubble is going to go and you can say block the narrow lumen, right? If the capillaries are present in the bones or muscle, the patient will have pain during the movement or even the resting condition, and that is known as bends. That is known as bends. If the person's CNS, you can say the cerebral capillaries, they are blocked. So what will happen over here? The cerebral capillaries, if they are blocked, then that is going to lead to stroke. And if in the lung it is blocked, so the patient will land up into difficulty in breathing and he will have the feeling of choking. So chokes. So bend, choke, strokes. These are the three symptomatic, you can say, presentations of this dysbarism, Casen's disease, or which is also known as decompression sickness. What do you think? Will the patient be happy? Yes, he'll be very, very happy. Why? Because he's going to land up into nitrogen narcosis. So that's how we completed the respiratory system. Let's discuss the homeostatic points. First is the terminal bronchiole. That is going to be generation number 16. IAP and ITP. During the rest, IAP is going to be 0. And if I talk about ITP, that is going to be minus 2.5 mmHg. If I ask about high compliance is seen in, only and only 3 different segments. That is emphysema patients, alpha-1 antitrypsin deficiency patients, or in the elderlies, that is old age subjects. Coming to the surface tension and surfactant. Surface tension is the inward force that is present because of the air-water interface. Air-water interface, because of that, what happens is inward force is generated. What about surfactant? Surfactant is mainly made up of lipids, and what is the major lipid? That is GPPC. Right, which is also known as lecithin, and the minor lipid is going to be sphingomyelin. That's why we take the LS ratio in the checking for the checking of fetal lung maturity. Now coming on to the FEV1 percentage, which will be increased in the RLD. I told you that in the OLD it is going to decrease. So please remember, it is going to be increased in the RLD, right? Then coming on to the mid-pontine lesion with bilateral vagotomy. The pons is also gone, upper pons is also gone, and the vagus is also gone. Definitely the person will land up into apneusis. Central chemoreceptors are sensitive for both, right? If the both is not there in the option, I'm going to mark it as H+ ion in the CSF. If that is also not in the option, I'm going to mark increase in the PCO2, because the PCO2 can directly stimulate the peripheral, but indirectly it can stimulate the central chemoreceptor. Let's coming on let's discuss the CNS system. The first thing is CSF versus plasma. What are the differences that they are going to ask you? Please remember that the CSF is going to have the low concentration of glucose, protein, calcium and potassium as compared to the plasma. Why? Because protein is holding on pressure. It is going to give the oncotic pressure. I don't want more oncotic pressure in the brain. Why? Because please remember, otherwise there will be edema-like condition which is going to take place. Now, osmolarity always going to be equal in case of ACF, ICF, as well as in case of plasma, as well as the CSF, right? And the bicarbonate concentration is almost equal to high concentration. Which are the things which are going to be produced in the high concentration in the CSF? That is going to be magnesium chloride and the carbon dioxide, right? What is the normal pressure of CSF? That is 7 to 8 centimeters of water or 70 to 80 millimeters of water. Now coming to the two types of synapses. There are two types. So what are the two types? First is the electrical synapse and second is the chemical synapse. Now we know electrical synapse means we are talking about the gap junctions. But see over here, gap junctions are present, I agree. They do the quick transfer. That is also I agreed upon. But what is the problem? The problem is they are bidirectional. They are bidirectional. So what will happen? Once one cell is stimulated, it is possible to have multiple stimulations because of the backflow of the electrolyte. So this is the bidirectional and that's why they are less than 1%. Why? Because the precision is not there. Precision is not there, right? Gap junction less than 1% and bidirectional. Where these are present in the neocortex, they are present in the inferior olivary nucleus, they are present in the cerebellum also, they are present in the suprachiasmatic nucleus, hypothalamus also. So in all these places, these are going to be present. Rest all the places we are going to have the chemical synapses. Yes, the chemical synapses will be slower and it will take a lot of time. Why? Because first of all, the action potential will move forward. Then the calcium will open. That will take time. Then the calcium will come inside. That will take time. Calcium will remove the complex in. That will take time. And the vesicles will get released. That will take time. And as soon as the neurotransmitter is released, it is going to go on and sit onto the receptor. That will take some time, which is known as, all these timings are known as synaptic delay. Yes, I'm going to have synaptic delay into the chemical synapses, but please remember they are going to be much more. How much more? 98 to 99%. Why? Because please remember, these are going to give us, these are unidirectional and these are going to give us the precision. And that's why we are going to prefer them. So, except these neocortex, inferior olivary nucleus, cerebellum, hypothalamus, suprachiasmatic nucleus, all the areas are going to have the chemical synapses because of their property of precision. Let's move on to the snare proteins. What are the snare proteins? Snare literally means the S, that is the synaptic snare, that is NSF attachment like protein, right? Attachment receptor like protein. Now let's talk about the snare proteins. There are two types of snare proteins. First is if they are attached to the V, that means vesicle, then that will be called as V snare. If they are attached with the axon terminal, then they will be called as T snares. Please remember, if you have synapto in the name, that will be your V snare, and shorter names such as SNAP25, syntaxin, they are your T snares. Now, if you want to remember one name, please remember synaptobrevin. What these are going to do, these are spring-like structures. They are going to coil with each other and cause the exocytosis. That's all their job is. Now, see over here, there are two toxins which we are going to talk about. First is the botulinum toxin. What happens is both of them inhibit the synaptobrevin, be that the botulinum toxin or tetanus toxin. But please remember, botulinum toxin is going to go and attack on the specific synaptobrevin, which is going to cause the release of acetylcholine. If acetylcholine is not released, especially at the neuromuscular junction, there will be no contraction. Not only that, even in the relaxing phase, in the relaxed condition, there will be no tone which will be available. Hence, the patient will land up into flaccid type of paralysis. How to remember? Remember A, B, C. Right? So, A means acetylcholine release will be inhibited by the botulinum toxin, which is going to cause the flaccid paralysis. Now, we can use that for our benefit or patient's benefit. How? The achalasia cardia, where the LES, that is lower esophageal sphincter, unable to relax. We are going to give a diluted form of the botulinum toxin, very minute dose, that will help the patient to have the relaxation. Then removal of wrinkles. Wrinkles are also one of the form of the continuous contraction phase, and as the age progresses, they go in the spasm, have the fibrosis, and that's why the wrinkles will come. In the spasm and contraction, we actually use these botulinum to get rid of the contraction. Then coming to the tetanus toxin. Tetanus, I told you, that is also going to inhibit the synaptobremin, but the synaptobremin will be the one which is going to cause the release of glycine. Glycine is inhibitory neurotransmitter. If you're going to inhibit the inhibitory neurotransmitter, of course, the excitation will occur. That means the muscle will keep on contracting, and that type of paralysis is known as spastic paralysis. So remember T for T. Tetanus toxin causes spastic paralysis. Why? Because it inhibits the inhibitory neurotransmitter. Coming on to the somatosensory system, please remember these are present in the dermis. All of these are present in the superficial dermis. There is only one thing which is present in the deep dermis, that is nothing but your Pacinian carpuscle. If I zoom it in, it looks as if it is having the concentric circle, and that's why it is going to be looking like a cut onion, right? Or this is known as onion-shaped Pacinian carpuscle, onion-shaped somatosensory receptor, which is present in deep dermis, right? One more thing that you have to see over here, that all of them are capsulated. Either they have capsules or disc which they are covered with, but there are free nerve endings which are also available, which are non-capsulated. Of course, they are present in the superficial dermis. And what is free in this world? The pain is free. So please remember, free nerve ending is going to carry the pain sensation. Let's see one by one their own functions. Let's see first of all the division. There is something known as rapidly adapting. What I mean by that? Let's say that this is the stimulus that we have given. How the response will be? Whenever from increasing to decreasing, that means when there is going to be change in the you can say any stimulus, then these are going to react. These receptors are going to give the you can say the response, all right? But when there is no change, there will be almost no response, all right? That means they're going to adapt very quickly. That's why they are called as rapidly adapting, and they are going to sense the rate of change, and that's why they are known as phasic receptors. They're not continuously active. They're active in the phases when the change is going to occur. And how to remember which one are the rapidly adapting ones? That is, Passy has messy hair. So please remember Pacinian, mesons and hair on ending, which is important for the light skin movement. So that is going to be, these three are the ones which are going to be rapidly adapting. What about slowly adapting? Rest all are going to be coming under the slowly adapting. Please remember free nerve endings. They are going to carry the pain sensation. Pain should not be adapted unless and until the primary healing takes place. So non-adapting are the free nerve endings. Please remember this is protective phenomena. If that is not in the option, go with the slow adapting, right? Next, what are their specific, you can say, functions? First thing first, Meissner's corpuscles. Please remember, Meissner's corpuscle, they are most abundant receptors present in the glabrous skin. What do you mean by glabrous skin? Non-hairy skin, where the hairs are not there, and that too before waxing, not after waxing. I'm talking about naturally non-hairy skin. That is known as glabrous skin. The palm of the hand and the sole of the foot, that is nothing but your most abundant receptors that are going to be present in the non-hairy or glabrous skin, right? So they are going to carry fine touch and 2-point discrimination. Remember that whichever is going to start with the MM, that is going to carry the fine touch and 2-point discrimination. What is the difference? We'll see. That means Meissner's and Merkel's, both are going to carry these sensations. Now, if I ask you what is 2-point discrimination, two different points should be able, the person should be able to perceive those two different points as two separate points, right? He should not feel that both the points as one point, right? So that is 2-point discrimination. It is best at the fingertips and lips, right? That means the distance. At a lesser distance, it can be perceived very nicely, but it is worst at the back of the scapula. Exactly on the scapula, it is going to be the worst. It is 60 to 70 mm, right? Where the 2-point discrimination occurs. So please remember, it is the worst there. Pacinian, P for Pacinian, P for pressure. It is not pain. Pain is free. So please remember, free nerve endings are going to carry the pain sensation. But on the other hand, Pacinian corpuscle, which looks like a cut onion shape or cocktail onion shape. So please remember that is going to be carrying the pressure sensation. Why? Because please remember, if I touch it, the deep dermis will not be activated. I have to give a higher threshold stimulus, that means pressure, or I have to give the high frequency vibration. So if I talk about low frequency vibration is going to be carried by Meissner's corpuscle. Please remember that high frequency vibration will be carried by the Pacinian. It is present in the deep dermis and joint capsule, which looks like a onion shape. Coming on to this. What is this? This is how the blind people are going to read. That is known as braille reading, right? So in the braille reading, who is going to help? The one which is very, very good at the 2-point discrimination. I told you MM receptors are going to be the ones which are going to sense the fine touch and 2-point discrimination. But the Merkel's disc are better. Why? Because not only they sense the 2-point discrimination, but they are going to sense the edges and points. And that's why these are going to be the best. Alright. So if they ask who is best, then you are going to mark Merkel's. And if they ask most abundant, especially at the glabrous skin, Meissner's. Alright. Then coming to the free nerve ending, we know that they are non-adapting and they carry the pain sensation. In the AIMS exam, once they have asked which channels are going to help them out, please remember the name TRP, that is transient receptor potential channel. They are going to be help them out to produce the action potential. Glabrous skin, we know that the Meissner's are going to be the maximum. Hair and organs, they are important for light movement on the skin. Coming to the pain, pain is not only of one type, it is having the dual transmission. First of all, there will be very, very sharp pain which will be seen, especially the superficial pain. This is also known as superficial pain. What is this pain? Any skin pain. That means any skin injury when it occurs. What is going to happen? There will be a sharp pain which will be noticed by a person. That is nothing but your fast pain, which is also known as epicritic pain. You exactly know where the pain is occurring, right? So this is well localized. And please remember, this fast pain is known as good pain. Why it is known as good pain? Because it is going to help me out to have the withdrawal from the noxious or harmful stimulus, right? So withdrawal reflex will be seen in this, and that's why this is known as the good pain. Now, this is carried by, we all know it is carried by A delta, and the glutamate will be released over here. In case of the slow pain, if I talk about slow pain, this is the visceral pain, which is slow pain, and it is not very well localized. So I can write it as diffuse and dull. Dull and diffuse pain will be there. I don't know exactly in which hepatocyte I'm having pain, right? I'll be having the right hypochondrium pain, but not exactly the location I'll be getting to know. Visceral pain, or this is also known as deep pain. This is also known as bad pain. Why it is bad pain? Because it is going to give me the ANS symptoms like nausea, vomiting, fever, tachycardia, all these things, which doesn't serve any purpose per se. And that's why this is known as the bad pain. And why it is dull and diffuse? Why I don't know exactly in which cell I'm having the pain? Because remember, in the cell, my deep pain receptors are not there. They are present in the covering, such as if I have a headache, that means the brain neurons are not having any pain sensation, but the dura mater is getting stretched, and because of that, I'm having the pain. In the liver, I have the capsule on the liver. That is nothing but Glisson's capsule. That is going to have the nociceptors. In the lungs, I'm going to have the nociceptors on the pericardium, not onto the alveoli. Heart, pericardium, right? So on and so forth. The coverings will have these nociceptors, right? And this is carried by C fiber. We know that. Please remember S for slow pain. S for substance P. S for substance P. So the substance P will be released from when the slow pain is there. An example, any you can say any visceral pain, angina, gallbladder pain, right? The appendicitis pain, any pain you can take for that matter, any visceral pain. Now coming on to the tracks, we have talked about receptor. Now I have to carry that action potential towards the brain for the processing. So how we write the anterior? We write like ant, right? Ant means one of the insects. So let's draw the ant. Let's say some insect like ant is crawling on your skin. What sensations you are going to have? You will have very crude touch, right? You are going to have the crude touch, and you are going to have the itching if it releases some new, you can say some substance it secretes, right? One more sensation, I don't know how to correlate with that, but you will remember, I hope, that is sexual sensation is also carried by the anterior spinothalamic tract. If they talk about the pressure detection, then it will be, that is known as barognosis, will be carried by the anterior spinothalamic tract. But overall, if they give pressure, that means the pressure discrimination, that will be gone in the posterior column, right? If they just said pressure, go and mark the posterior column. What about lateral? If somebody kicks you, that means in Hindi we call it as lath marna. So what will happen? First of all, you will have pain and you will be red hot in anger. That means temperature will rise. So remember, pain and temperature will be carried by the lateral spinothalamic tract. Except pain, temperature, crude touch, itching and sexual sensation, rest all sensation will be carried by posterior column. All right, and how they are going to carry forward these sensation, let's see over here. First of all, the anterolateral spinothalamic tract. Why it is known as spinothalamic? Because the second order neuron is going to start in the spinal cord and it is going to go towards the thalamus. See over here, first order neuron, as it is going to come from the receptor, it is going to end in the spinal cord itself. As soon as it ends, what happens is it is going to cross over in the spinal cord and going to go towards the thalamus. This is the second order neuron, which is shown in the green color, and from the thalamus it is going to go towards the somatosensory cortex. If I talk about the posterior column, the scenario is somewhat different. What is the scenario? First of all, see over here, the first order neuron will enter and it is not going to cross over in the spinal cord, rather it will go in the medulla. In medulla, it is going to give the second order neuron, and second order neuron, it is going to cross over in the medulla itself and it is going to go towards the thalamus. Third order neuron is same as the anterolateral spinothalamic tract. It is also going to go from the thalamus to cortex. Now the thing is, if let's say the patient is having the the left hemisection of the spinal cord. Now what will happen over here? So please remember, if the person is having hemisection of the spinal cord, so if I say that these are the two tracks, so what will happen if I cut over here, let's say on the right side, if I have the hemisection of the spinal cord, so what is going to happen? See, whatever dorsal column which is going to come from the right side, that will be gone, and whatever left-sided anterolateral spinothalamic has come, that will be gone. That means this is the hemisection of spinal cord, that is known as Brown-Sequard syndrome. This is known as Brown-Sequard syndrome. Here, whatever sensations are carried by the anterolateral spinothalamic tract, they will be lost on the contralateral side. That means pain, temperature, crude touch, itching, but the patient will come to you with the complaint of pain and temperature. With that, all the sensations which are carried by the anterior tract, also the crude touch, itching, as well as the sexual sensation, that will also be gone on the contralateral side, and rest all which is carried by the dorsal column, they will be gone on the same side, that is known as ipsilateral loss of the sensation which are carried by the dorsal column, right? So please remember that even the motor sensation will be gone on the ipsilateral side only, Brown-Sequard syndrome. Now, it will be carried and finally it will reach to the post-central gyrus, which is the sensory cortex. What it is shown, it is known as homunculus. What is the homunculus? It's the imaginary map of the cortex depending on the neural connection of that particular area of the cortex towards the particular body part. Now, if you see, the maximum area is given to the face and hand. Maximum area is given to the hands and face, and in the hand, maximum area is given to the thumb, and in the face, it is given to the lips, right? So this is the motor, you can say motor cortex, that is present in the frontal lobe, pre-central gyrus area. It depends on the uses of the body part. If the body part is getting used too much, then more area will be given to that particular body part, and the least is given to the trunk and hip. There is something known as cortical plasticity. If anything is plastic, it is moldable. So please remember, their connection, their synapses are moldable. If the person is blind, those neurons will not degenerate, rather they will have the connection to the neighboring neurons and they will help in that particular function, right? So ability to form the new synapses with the neighboring area, that is known as cortical plasticity, and that is the reason behind the phantom limb pain. If in the option you have cortical plasticity, go and mark the cortical plasticity for the phantom limb pain, because this is the readily accepted theory and this is the new theory. Previously, we used to say that that is because of the law of projection, right? If you don't have cortical plasticity, then only mark the law of projection. If both are present, then go and mark the cortical plasticity. Now coming to the special senses, see over here, if I say that this is the dark current, now in the dark current, what is going to happen? The depolarization occurs. And whenever the stimulus is going to fall on the retina, the hyperpolarization occurs. This is the special thing about this special sense of vision. Right? How this is possible? Please remember, during the resting condition, there are something known as sodium channels, which are cyclic GMP gated sodium channels. They are going to be open. Why? Because I have cyclic GMP during the rest. But as soon as light is going to fall onto the retina, what happens is, in the rods and cones, we do have 11 cis retinol, which is going to be converted into all trans retinal. Please remember, it is retinal, not retinol. Retinal is nothing but your aldehyde, alright? So aldehyde, you don't have alcohol in your eyes. Please remember, as soon as this 11 cis retinal will be converted into all trans retinal, what is going to happen? All trans will be activating one protein which is known as transducin, which will activate the phosphodiesterase, which is going to cause the hydrolysis of this cyclic GMP. If the cyclic GMP is not there, the sodium channel will close, no more influx of sodium. So what will happen? Ultimately, hyperpolarization will take place. Light causes the conversion of cis into trans. Please remember that. Coming to the hearing, what is the special thing about hearing? Everywhere in the body, the potassium is more inside the cell. But in the scala media, we do have something known as stria vascularis. What is the role of stria vascularis? It takes the potassium from the blood and put it into the scala media. So please remember, the potential which is generated in the endolymph as compared to perilymph, that is going to be more positive. That is because of the potassium secretion via stria vascularis, and that is known as endolymphatic potential. And this is why whenever the potassium channels are going to open, you know that how the vibrational energy is going to get transported. First of all, it will come in the external auditory meatus, then it is going to vibrate the tympanic membrane, that will vibrate the malleus incus stapes, that is miss, and that is going to vibrate finally the oval window. As soon as that vibrates, the perilymph is going to vibrate and the basilar membrane is going to vibrate. And on the hair cells, we have cilia, they are going to move and that will open up the potassium channel. Please remember, over here, potassium is more outside of the cell. So potassium entry, that will be responsible for the depolarization, right? So that is the special thing about this special sense, and that is known as, everything is happening in the cochlea. So this is known as cochlear microphonic potential. This vibrational energy will be converted into action potential, right, in the cochlea. So these are the potassium, you can say, channels. You can see over here, as soon as the hair cells are going to move, these are known as tipplings. That is nothing but the connection between kinocilium and the different stereocilias, right? And they are connected with the spring-like structure. They are going to open as soon as the hair cells are going to move. Now coming to the auditory cortex, the listening or hearing, you can say processing or whatever you hear, that is going to happen in the area number 41 and 42. But there are some other areas which are also responsible for that, which are present in the temporal as well as frontal cortex. In the temporal lobe, especially in the superior temporal lobe, I'm going to have one area which is known as Wernicke's area. This Wernicke's area is important for comprehension of the speech or the understanding of the speech, right? And that area is area number 22. Area number 22. What is going to happen if there is any defect in this area? The comprehension or understanding of the speech will not occur. Will he be able to talk? Yes. Why? Because the talking area or motor area is different. This is the sensory area for the speech, right? So he is able to talk fluently. So that is known as fluent aphasia. But what is the problem? He is not talking any sense to us. So this is known as nonsense aphasia also. Nonsense aphasia. Right? Fluent aphasia, sensory aphasia is also one of the terminology for this, or Wernicke's aphasia. All are the same when the lesion is there in the Wernicke's area. Please remember that. Now, what is the motor area? Motor area is the Broca's area, right? Where this Broca's area is present? Broca's area is present in the inferior frontal gyrus area number 44. Bolna. For bolna, you require, bolna means to talk, right? For talking, you require a lot of muscles, right? You have to articulate the tongue muscle, vocal cords, the oral muscles, right? So please remember, bolna is the motor activity. If Broca's is damaged, then definitely motor speech will be affected. Understanding is perfectly fine. So he will have non-fluent speech, but that is known as motor aphasia also. Non-fluent aphasia, motor aphasia, Broca's aphasia, one and the same thing, but he is going to understand each and everything. Please remember that. He will talk with a lot of pauses. Why? Because the articulation is not proper. Alright. Now, please understand that there is fasciculus that is known as arcuate fasciculus. Arcuate fasciculus, that is going to be damaged, and if that is damaged, the conduction will not occur from the vernicase to the Broca's area. This is known as conduction aphasia, in which naming of the object will be affected. That is known as anomic aphasia. If all of them are damaged, then this is going to be called as the global aphasia. Alright, so this is what the diagram is. Please remember, there is going to be central sulcus. Behind that, we are going to have post-central gyrus. S is there, so please remember, this is nothing but the sensory cortex area number 1, 2, 3, 5, 7. Alright, and 4s and 6s are very, very important in the cricket. Why? Because they are going to show the motor skills. So for motor skills, we require area number 4 and 6, which is present in the pre-central gyrus. Please remember that. Now, coming on to the pyramidal tract are the corticospinal tract and corticobulbar tract. Mainly, we talk in terms of corticospinal tract, that is more important for us. Now, at the medulla, what happens is 80 to 85% of these tracts, they are going to decussate. That means they are going to cross over, and whatever fibers they cross over, that is known as lateral corticospinal tract, and they are known as the pyramidal tracts. Okay, they are the pyramidal tracts. They are going to supply to the distal limb muscles, especially distal muscles, or we can write distal limb muscles. And what they are going to do, distal muscles are very, very important for the skilled fine movement, writing, painting, driving, all these things, right? So for that I require, that means for the skilled voluntary skilled and fine voluntary skilled movement, for that I am requiring these pyramidal tracts and the distal muscles, right? So pyramidal tracts are going to help me out in that. Now, talking about the extrapyramidal tract, what are those? We'll see that. But remember, they are going to supply to the axial muscles like trunk muscles or the back muscles, right? So those are only, they are not going to do any skilled movement, but they are required for the tone, posture, balance, all these things. Alright, to maintain the posture, balance, they are required. Alright, extrapyramidal tract, which are going to supply to the axial muscles. Now, there are 4 major extrapyramidal tract. Remember the name. What are those? Tectospinal tract, which is going to come from the superior colliculus. Rubro is going to come from the red nucleus. Now, reticulospinal tract is of 2 types, pontine and medullary. You can see the pontine is going to stimulate the gamma, you can say motor neurons of the extensor of the upper limb as well as lower limb. And if I talk about vestibulo, then it is going to supply to the upper motor neuron, especially the extensor of the lower limb, right? Then who supplies to the upper limb? Alpha motor neurons of the upper limb is supplied by the rubrospinal tract. Now, see over here, reticulospinal tract, if it is the pontine reticulospinal tract and the medullary reticulospinal tract. So, pontine is going to stimulate and the medullary is going to inhibit the gamma motor neuron of the extensor muscles, right? Tectospinal, that is going to come from the superior colliculus. It has no role per se. We are going to see the applied aspect, right? That is important for us. Vestibulospinal, that is going to supply the alpha motor neuron, especially to the extensors of lower limb. Let's talk about rubrospinal tract. Please remember, rubro also supplies the alpha motor neuron, but this is going to supply to the flexor muscles of the upper limb. Now, If you want to remember only two tracks, so remember rubrospinal and reticulospinal tract. So please remember the reticulospinal, especially the pontine, that is going to be stimulated via the sensory, that is ascending tracts also. The ascending tracts while going towards the sensory cortex, they are going to stimulate to the pontine reticulospinal tract. Now see over here, if the person is having decorticate rigidity, that means all the cortical neurons are gone and they are having the inhibitory control on all of them. So please remember, rubrospinal, on it the inhibitory control is gone. That means it is going to be overly active. It is only going to be coming out via cervical. Now what it will do to the upper limb? It will cause the flexion. Why? Because it is going to supply to the flexor muscle, right? So this will be active and it causes the flexion of the upper limb. Now what about the pontine reticulospinal tract? It is active as compared to the medullary, and that's why it is going to activate the gamma motor neuron, and that too of lower limb. So what will happen because of that? So if the person is having decorticate rigidity, upper limbs are going to be flexed, lower limbs are going to be extended. Let's see, if the lesion is there between the superior and inferior colliculus, we know that the rubro is going to come from the superior colliculus, so this will be gone, right? Only the reticulospinal tract, that will be intact. So now what it will do is that not only it is going to cause the extensor of the lower limb, but also since the cervical fibers are also going to come out of the reticulospinal tract, it causes the extension of the upper limb also. How to remember this? See over here, both the limbs are extended. So if you have many E, that is decerebrator. So please remember, both the limbs are going to be extended. Only in the decorticate, the rubro, corticate, in that the rubro is intact, and that is why the flexion in the upper limb is taking place. Please remember that. Now coming on to the upper motor and lower motor neuron lesion. UMN means upper motor, LMN means lower motor. There are two lower motor neurons, alpha motor neuron. We have seen that in the Erlanger-Gasser classification, and gamma motor neuron. Alpha means acha bacha, a good kid. What we do to the good kid? We always stimulate that. So upper motor neurons are like a parents to the lower motor neurons, and on the other hand, the gamma is ganda bacha, right? Naughty kid. So we are going to inhibit that kid. Now both are important. Why? Because when we are going to stimulate the alpha motor neuron, it is going to cause the voluntary contraction, isn't it? It is going to cause voluntary contraction. On the other hand, gamma is important for the resting tone, right? If I say that there is a lower motor neuron lesion, that means both of them are gone. So there will be no voluntary contraction and no tone. So this type of paralysis will be known as, yes, paralysis is going to be there, and this type of paralysis is known as flaccid paralysis. Why? Because the tone will be gone too, right? If I talk about upper motor neuron lesion, now let's talk about upper motor neuron lesion. If the upper motor is gone, that means the stimulation of alpha is gone. That means there will be no voluntary contraction. So again, the person will land up into paralysis. But understand, the most important thing in this is the inhibition on the gamma motor neuron is gone. That means gamma is now overly active. It has increased the tone into the muscles. So that is going to land the patient into spastic paralysis. That is going to land up the patient into spastic paralysis. So please remember that. If we have upper motor neuron lesion, so what will happen to the tone? The tone is going to be increased. Exaggerated reflexes. DTR means deep tendon reflexes will be exaggerated. That means highly active, exaggerated reflexes will be seen. On the other hand, the hypotonia, that means the tone is going to be lower. Hypotonia or even atonia can be seen in case of the lower motor neuron lesion, and over here the reflexes are going to be very mild, or they are even absent. Muscle atrophy, it will be seen if the lower motor neuron is lesion. Why? Because there is no one to stimulate the muscle. On the other hand, gamma motor neuron is overly active. It is continuously stimulating the muscles. So that's why this is not seen. That's why this is not seen in the upper motor neuron lesion. Fasciculation and fibrillation. If in the group of muscle, we are going to see the twitches, involuntary twitches, that is known as fasciculation. In the single muscle fiber, if the twitches are coming, that is known as fibrillation. So please remember, because of both of them, what will happen? Of course, because of them, the twitches will be seen, and that is going to be present in the lower motor neuron lesion. On the other hand, this will not be seen in the upper motor neuron lesion. This is because of the phenomena of denervation hypersensitivity kind of a phenomena. What happens in the denervation hypersensitivity? That there will be upregulation of receptor, and that's why these twitches are seen, right? On the other hand, if I talk about the upper motor neuron lesion, then the person is going to have the Babinski's reflex positive. Babinski's reflex positive. What do you mean by Babinski's reflex? Let's see that. Now, if I strike the sole of the the foot of the person like this, in this manner, upward and medially, what will happen? Normally, the adult have negative Babinski. That means there will be plantar flexion which will be seen, and all the toes, they are going to come together. There will be adduction of all the toes that is going to be seen. But if the patient is having upper motor neuron lesion, then what will be seen? The Babinski's sign. This is the Babinski's sign. Babinski's sign. The Babinski's sign is going to be positive. The Babinski's sign is going to be positive. That means there will be dorsiflexion, especially the dorsiflexion of the thumb, and fanning of the all toes. So please remember, the dorsiflexion of the great toe and the fanning out of all other toes will be seen. So how to remember? The quacks are there which are actually deteriorating the patient's condition. So ऐसे ढोंगी बाबा को ऊपर भेजना चाहिए, सीधा, send them upward in the sky, right? So please remember, Babinski's sign is positive in the upper motor neuron lesion. Coming to the stretch reflex, if you stretch a muscle, what will happen? Definitely the length of the muscle is going to increase. The length of the muscle is going to increase, but to have that sensation, I should have the length sensors. So what are the length sensors? Please remember, the length sensors are muscle spindles. So muscle spindles are going to get activated. So I'll write it like this. So who is the length sensor? Length sensor is spindle length sensor, right? As soon as they are getting stimulated, afferent nerves are going to get activated. That is 1A and 2 afferent nerves. They are activated and they will go and activate the alpha motor neuron. If the alpha motor neuron is activated, we know that there will be muscle contraction which will be seen. And whenever the muscle contracts, what will happen to the length? Length is going to decrease. So when the muscle is contracted, that is going to decrease the length. That is going to be the response when the muscle is stretched. So that stretch should be passive stretch. It should not be voluntary stretch. When I stretch a muscle of some other person passively, then he is going to show the contraction response. That is known as the stretch reflex. It is also known as loading reflex because the muscle is contracting. DTR, deep tendon reflex, is myotatic or segmental reflex. This is also known as monosynaptic reflex because synapse is communication between two neurons. Only one synapse is there between the 1A and 2 afferent nerve and the alpha motor neuron. That's why it is known as monosynaptic reflex. Coming on to the inverse stretch reflex. Over here, if you give the excessive passive stretch, I'm just writing stretch. Always this should be passive, right? What happens? Rather than muscle contraction, the muscle relaxation is seen, and that's why it is known as inverse stretch. And when the muscle relax, it is going to increase the length. So that's why it is known as lengthening reaction. Now what happens? Due to excessive stretch, not the length, now the tension will increase. And when the muscle tension is going to increase, there are tension sensors which are going to get activated. What are the tension sensors? Tension sensors are Golgi tendon organ. So please remember, tension is tendon, okay? So tension sensors are the tendon organs, right? GTO. Now they are going to activate the 1B type of nerves, and that is going to cause the activation of, inhibitory interneuron. Inhibitory interneuron, the name itself suggests that that is going to go and inhibit the alpha motor neuron. As soon as the alpha motor neuron is inhibited, the relaxation of the muscle will occur. Now see over here, one synapse is there in between the 1B and the inhibitory interneuron. And again, there is a second synapse that is between the inhibitory interneuron and alpha motor neuron. That's why this reflex is also known as disynaptic reflex. Disynaptic reflex. Now, if we talk about the intrafusal muscle fibers and the extrafusal is supplied by alpha, and intrafusal, that means whichever is present in that muscle spindle, they are going to have two types of fiber. One is the chain fiber and the second is the bag fiber. These chain fibers, they are going to have the nuclei which are lined in the straight format. That means they can only move in the forward or backward direction, and they are responsible for resting length. That means when the muscle is about to start the contraction, that is the initial length, and after the contraction, what is the final length? They will only give me the static values. Okay, so that's why they are known as static fibers. All right, then in the dynamic, I have both the types of fiber, static as well as dynamic. So if they ask during muscle contraction, who is going to sense the signal, in which angle, for how long, in with what intensity the muscle is moving right now, then I require these back fibers. They can move in any direction and they can tell me the change in the length per unit time. When we consider time, that is going to be called as dynamic. So they are going to give me the velocity and motion. So please remember, bags are going to give me the velocity and motion. So let's move on towards the sleep and EEG waves. What is EEG? EEG is electroencephalogram. It is going to give us the mainly 4 waves, can give the gamma also, but we'll talk about it later. So please remember 4 waves. What are those 4 waves? Beta, alpha, theta, delta. All right. So I have the mnemonic that is bat dance. All right. So beta, alpha, theta, delta. So please remember why I have this mnemonic. D for deep sleep. So as the activity of the brain is low, you're going to have lower frequency, 0 to 3 Hertz for delta, 4 to 7 Hertz for light sleep, that is going to be theta, and then we are going to have 8 to 13 Hertz, that is going to be alpha, and the maximum when the person is awake and the eyes are open, he's going to have beta waves. Beta waves when the person is awake and he's doing some mental activity, right? Remember, alpha wave is like a meditation condition. The brain is awake, but you have eyes closed. As soon as you have eyes open, you're going to land up into beta waves. So please remember that. These are the areas of the brain from where they are produced. Beta waves are produced from the RAS, that is a reticular activating system, which is going to go and stimulate the cortex. Then we have the alpha wave, which is going to be generated by the parietal as well as occipital cortex and thalamus. Hippocampus is going to be responsible for theta wave and thalamus is responsible for delta wave. Delta is for D. D for deep sleep. So please remember deep sleep. Right? There are 2 types of sleep. What are the 2 types of sleep? So please remember NREM and REM. What is the REM? REM is a rapid eye movement sleep, and REM for remember. So please remember remembered. The dreams are going to come in both the types of sleep, NREM as well as REM. But where they are remembered? They are remembered in the REM sleep. And if the dreams are scary and they are remembered, that is known as the nightmares. If the scary dreams come in the NREM, of course, they will not be remembered. And if they are not remembered, then the person will wake up frustrated and scared, but he doesn't know why he is like that. So that is called as night terror. The scary dreams, fearful dreams, not able to remember. That is the night terror. And in the NREM sleep, the person is going to have different parasomnias, altered events that are known as parasomnias. Sleep talking, which is known as somniloquy. Right, sleepwalking, somnambulism, bruxism, nocturnal enuresis means bedwetting. Please remember, bedwetting is normal till 5 years of age. So in the small kid, bedwetting is normal, but as the age progresses, if still the person is having bedwetting during the night, that is not normal. All right. Please remember the NREM has 3 different types. Just remember, if you want to remember one point, that the NREM 3 and 4, usually it was 3 and 4, now they have come in the 3 only, right? So that is the deep sleep, and NREM 2 has 2 hallmark. What are those? Sleep spindles and K complexes. Now coming on to the REM sleep. So please remember that the REM sleep is the hallmark of this REM sleep is the PGO spike, that is pontogeniculo-occipital spike. Why PGO spikes? Because these spikes are generated from these particular areas of the brain, right? This is known as paradoxical sleep. Why? In the sleep, the brain activity should be low. So low frequency waves should come. But see over here, high frequency waves are coming. Alpha, not only that, beta waves are also coming. So there is a paradox which is going on. And that's why we call it as paradoxical sleep. Plus, we don't want to act out of the dream, right? So that's why we are going to have the muscle atonia and the locus ceruleus, which is responsible for this, and this is going to release the norepinephrine, because of which there will be muscle atonia which is going to happen. Now, I want to respire. That's why the respiratory muscles and this is the rapid eye movement sleep. So the eyes are moving. That means the extraocular muscles are spared from the atonia. These two muscles will not have atonia. Rest all the muscles will go in the atonia. Please remember these two types. Coming on to the hypothalamus, we are going to cover it in the short. The circadian rhythm that is maintained by a nucleus. Remember, circadian rhythm means the 24 hours clock, which is the internal clock of my body. If on particular time I am waking up for 60-70 days, my body will wake up at the same time on the next day also. That is known as the internal clock has set to that particular time, right? So that is nothing but the circadian rhythm, which is maintained by the suprachiasmatic nucleus, right? Coming on to the autonomic nervous system, it is mainly maintained by the paraventricular system, and lateral hypothalamus can also help us out, but mainly it is controlled by the paraventricular nucleus, that is sympathetic and parasympathetic system. The sexual behavior is maintained by the anterior hypothalamic nucleus, or you can say the preoptic nucleus. Anterior hypothalamus, in that we are going to have the preoptic nucleus. The thirst is controlled by lateral hypothalamus. The fun fact is the hunger is also maintained by lateral hypothalamus. The anger is also going to activate the lateral hypothalamus. You might not be angry, you might be hungry. So eat and calm down, right? And please remember, thirst is maintained by this lateral hypothalamus. When you feel thirsty, whenever the plasma osmolarity is high or the volume of the blood is low, even the angiotensin 2 can activate the osmoreceptor. What are those osmoreceptors? Please remember two names, that is SFO, subfornical organ, or OVLT, that is organum vasculosum lamina terminalis. Alright, so these are two osmoreceptors which are going to get activated and they are going to stimulate the lateral hypothalamus. Now coming to the appetite regulation, there are two centers, that is the ventromedial nucleus and the lateral nucleus. Just now we saw, because if you want to activate the lateral nucleus, you must be hungry, then only this lateral will be activated. And if you have decrease in hunger, or you have eaten something nice and you are satisfied with the food, now the satiety will come, and for that ventromedial nucleus of the hypothalamus will be activated, right? Now there are some hormones that you have to remember. Please remember the hormone mango. When you see mango, you will get hungry, right? What is mango? Melanin concentrating hormone, a gouty related protein, neuropeptide Y, ghrelin and orexin. Remember, the orexin not only causes hunger, but it is important for wakefulness, right? If these neurons are not working properly, the patient will land up into narcolepsy. What about satiety? Please remember, the satiety hormones are MSH, and that too specifically alpha MSH. If MCH comes, that will cause hunger. MSH is going to come, then it is going to decrease the hunger. That means it is going to cause the satiety. Then we have leptin. This is going to have the dual role. Please remember, that is going to stimulate the MSH and that is going to inhibit the AGRP and neuropeptide Y. This leptin is important in the you can say permissive role in the puberty also. That causes the pulsatility of the gonadotropin releasing hormone, because of which the LH and FSH will be released in the pulsatile manner. if this leptin is very, very important for the satiety, if that is not there or not working properly, the lesion is there, then the person will land up into obesity, and that is known as the familial obesity. What are the other hormones which causes satiety? Insulin and other intestinal hormones such as CCK, secretin, so on and so forth. So please remember this chart. Let's move on to the next thing, that is sleep and wakefulness. Just now we saw that wakefulness is maintained by orexin. All the hormones which activates the sympathetic system, that is also going to activate the wakefulness, that is norepinephrine, epinephrine, serotonin and histamine. Please remember the IPSP neurons, which are going to create the inhibitory postsynaptic potential, specifically the neurotransmitters, that is GABA and acetylcholine, they are responsible for sleep, and these hormones, they are responsible for wakefulness. What about temperature regulation? In the temperature regulation, please remember the air conditioner, and that too a window air conditioner. Alright, so we used to have the window air conditioner wherein the fan used to be there in the front and exhaust used to be at the back. So if the person is feeling hot, he will stand in front of the AC. He is feeling very, very cold in the cold environment, he will stand at the back. So please remember this as hypothalamus. So if you have to adapt in the hot environment and reduce the body's temperature, you will activate the hot adaptation mechanism, that is nothing but anterior or ventromedial nucleus of the hypothalamus. If it's a cold environment, you want to adapt in the cold environment, then you will activate the shivering, constriction, vasoconstriction, right? All these mechanisms via activating the posterior or dorsomedial nucleus of hypothalamus. Coming on to the regulation of endocrine secretions, that is also going to be done by the hypothalamus, and synthesis of posterior pituitary hormones such as ADH and oxytocin will be done by this hypothalamus, right? And ADH is secreted by supraoptic nucleus. So please remember the name supraoptic nucleus, and pyar, that means love. So paraventricular nucleus is going to be responsible for oxytocin release. This paraventricular nucleus is responsible for maintenance of ANS, and this is also responsible for release of CRH, that is cortisol releasing hormone. Then some releasing hormone and inhibitory hormones are also produced by this hypothalamus. So please remember, such as GHRH, that is growth hormone releasing hormone, or GHIH, that is growth hormone inhibitory hormone, which is also known as somatostatin, which will be released by the hypothalamus. All right. Let's talk about the Papez circuit. Now, what is the Papez circuit? It is the window of limbic system. The limbic system is, again, it is present in the amygdala and various parts, which is going to make a circuit which is known as Papez circuit. So let's see what are the parts. First of all, how to remember these parts? These parts can be remembered by the mnemonic, that is MAC, P, Hippo. What is MAC? MAC is MAC, that is mammillary body, anterior nucleus, cingulate gyrus. P is PE, that is parahippocampal gyrus, entorhinal cortex, and hippocampus. So MAC, P, Hippo. Please remember that. Now, let's start with the mammillary body. Mammillary body is going to go towards the anterior nucleus of thalamus, and that is why it is called as mammillothalamic tract. Mammillothalamic tract. Now, please remember, the mammillary body is important for recent memories. And the anterior nucleus of thalamus, it is the relay center for various emotions and sensations. Then through the internal capsule, it is going to go towards the cingulate gyrus. The cingulate gyrus is important for cognition. Cognition means whatever understanding you have about a particular thing, that will be processed and understood by your brain. That is cognition, and also it is emotional memory. It is important for this emotional memory also, right? ANS symptoms such as the ANS control, such as heart rate and control, such as the heart rate and blood pressure, is also maintained by this cingulate gyrus, and from the cingulate gyrus, the signals are going to go towards the parahippocampal gyrus through the cingulum. Now, this parahippocampal gyrus and the entorhinal cortex, please remember, they are important for spatial memory. where the shop is exactly, or where a particular thing in your house, right? You have the orientation of that particular object in the space that is available. Hippocampal gyrus, we all know that it is going to be helpful in the conversion of short-term memory into long-term memory. Short-term memory to long-term memory. And via the phonics from the hippocampal gyrus, this signals are going to again go towards the mammillary body. So please remember MAC, PAY, Hippo, that is the Pape circuit. Let's move on to the associative learning or conditioning, which is given by Ivan Pavlov. He was the Russian scientist. He gave the associative conditioning in which the amygdala and cerebellum, they are going to play important role. Now let's see how this is going to be, learned or conditioned. Now, he bought a puppy and he wanted him to salivate after ringing a bell. Whenever first time he rang a bell, the puppy says whatever, right? Puppy hadn't have any salivation, no response. But when the Pavlov gave the food to him, the salivation started. Remember, after looking at the food, the salivation started. Nobody taught that puppy this, right? That means it was the unconditional response. And that's why the stimulus after which this unconditional response is going to come, we're going to call that as unconditional stimulus. So food over here is unconditional stimulus. Now, he wanted to condition his brain, doggy's brain, that after ringing a bell, he should salivate. So what he started to do is, he started to pair them together, ringing of bell, and after 15 to 30 seconds he used to give the food. Now after some time, when the Pavlov started to repeat this multiple times in the doggy's brain or puppy's brain, what started to happen? The association between ringing of bell and food started to occur. After some time, the puppy's brain will understand that yes, there is a ringing of bell, that means after some time I'm going to get the food, and without even looking at the food, he started to salivate, right? So if there is a conditioned stimulus by which you're going to get the response, that is saliva, without any food in between, this is known as conditioned reflex, and this is the Ivan Pavlov's, you can say, experiment of associative conditioning. Whenever unconditional stimulus is going to be given, it is going to be give us the unconditional response. Please remember, whenever unconditional stimulus is there, with or without the conditioned stimulus, we don't know because of which the response has come. We are going to assume it is because of unconditional stimulus. So whenever the food is going to come, it is going to be unconditional response only. Now there is another type of conditioning that is known as operant conditioning. That means the animal or human beings, they are going to learn particular things via operating on their own in the environment. Nobody will condition their brain or nobody will teach them. Now what we used to do in this experiment, this is done by the Skinner. The scientist Skinner has done this experiment. Now in that, what we have done is, we are going to cage the rat and we are going to place two levers, right? Over here you can see green lever and then the red color lever. Whenever he is going to press the green color lever, he is going to get the food. But whenever he is going to press the red color button or lever, he is going to get a mild shock, right? So what he will do, he will multiple times, he will try and do the errors, right? And whenever now he knows after some repetition that red means shock and green means food, right? So whenever he is hungry next time, he is going to apply the or press the green color lever, not the red color. So he learned via operating in that environment. The last topic is synaptic plasticity. What do you mean by synaptic plasticity? I told you plastic means something which can be modulable, right? So synaptic plasticity, synapses can be formed and changed, right, and formed again and again. So with that help, we are going to form the memory also. So let's see. First type is post-tetanic potentiation. What is post-tetanic potentiation? If you are going to, let's say, take the example of OTP, you're going to get the OTP. What do you do when you have to shift the window? At that time, you repeatedly say that number or that particular alphabets, right? And that's how for shorter time you remember that OTP. But it will last only for few seconds and minutes. As soon as the work is done, your brain is not going to give much importance to that particular thing, right? So this is also known as working memory, which is going to last for seconds to minute. That is nothing but short-term memory, short-term or working memory. All right, and that is the post-tetanus potentiation, which is responsible for this. What happens in this? When we give repetitive stimulus, we repeat that number multiple times or alphabets. What is going to happen? There will be increase in the calcium ions, and because of that, the neurotransmitter release will be increased temporarily. That is known as post-tetanic potentiation. Now, what is long-term potentiation then? Long-term, that means when we want to convert the short-term memory into long-term memory, this is going to be helpful. Now, in its name only, there is a long-term. That means long-term memory will be formed. This will be formed with the help of CA1 neuron. Cornoaminous neuron. There is an area which is known as Somers area, in which the CA1 neurons are going to help us out to generate this long-term memory, in which what is going to happen, as soon as you repeat something multiple times, what is going to happen? The glutamate will be released, and that is going to go and stimulate the NMDA receptor. These NMDA receptors will have some ionic changes, stimulation of AMPA receptors also, and finally they are going to activate multiple protein kinases, right? Even the calmodulin kinase and different kinases, that is going to give us the response, and that response is mainly because of increase in the protein or phosphorylation of particular protein. The protein changes are going to stay there for longer time, even till the years also. So please remember, this is the long-term memory which is going to be generated via long-term potentiation. For that, multiple revisions are important, right? Now, coming to the long-term depression, it is opposite to that of the long-term potentiation. When you stimulate the particular neuron for longer time, what is going to happen? It potentiates, that means it increases its response. But long-term depression means, let's say you are learning any skill, let's say driving, right? You exactly don't know where the gearbox first few times, but when you repeat that multiple time, whatever errorful, let's say the gearbox over here is at 8-degree extension on the left hand side. First of all, your extension can occur 7-degree, 6-degree or 11, 10-degree. Now, these are errorful pathways except that 8-degree extension. So, that will be stayed like that, but the other errorful, incorrect pathway or wrong pathways, they are going to get depressed, right? And that's how the skill is going to be enhanced. So, in those errorful pathways, we are going to release GABA, which will produce IPSP, and with that, the motor memory is sharpened up. So, we are going to depress the errorful pathways, right? And this is going to happen in the motor memory, in which cerebellum plays important role. Coming to the homeostatic points for the CNS, snare protein involved in the botulinum as well as tetanus, it is going to be synaptobrevin. Please remember, the botulinum is going to be responsible for inhibition of acetylcholine release. On the other hand, this is responsible, tetanus is going to be responsible for inhibition of glycine release. All right. Rapidly adapting receptors, what was the mnemonic? PASI has messy hair. Now I am changing the spelling because Pacinian means and hair on ending. Brown-Sequard syndrome, in that we are going to have contralateral loss of sensation, which will be carried by lateral as well as anterior spinothalamic tract. That is nothing but pain, temperature, crude touch, itching and sexual sensation. On the other hand, ipsilateral loss of sensations, which are carried by the dorsal column, right? That is nothing but all other sensation. Greater distance in 2-point discrimination, that means greater distance means it is pathetic. The 2-point discrimination is pathetic, that is at back, right? That is poor or worst. Decorticate versus decerebrate posture. When you have so many E's, please remember both upper as well as lower limb will be extended. And the pontine reticulospinal tract is responsible for this. On the other hand, if I talk about the decorticate, rubro will be intact, and because of that, what is going to happen to the upper limb? Upper limb will be flexed, right? And the lower limb will be extended, right? Frequency of EEG wave, we remember that via BAT dance, right? Beta, alpha, theta, delta, 0 to 3 Hz, delta wave 4 to 7 Hz, a theta wave 8 to 13 is alpha, and 14 to 30 Hz is beta wave. Role of hippocampus in the memory is it converts the short-term memory into long-term memory. But remember, they can ask you where the long-term memory is stored. It is stored in the neocortex. It is different. Conversion occurs with the help of hippocampus. Conversion mein hippocampus is going to help, but storage is going to occur in the neocortex. Let's start with the renal system. Renal system, what is the structural and functional unit of renal system? It is none other than the nephron, and please remember it has the maximum blood flow per unit area. That is nothing but per 100 gram per minute. How much? 1250 ml, right? 1250 ml per minute is going to be the blood supply. It is almost 20 to 25% of the cardiac output. High blood supply per 100 gram. Maximum blood flow is asked at the rest, then the answer will be liver. Maximum blood flow per 100 gram per minute is asked, then your answer will be kidneys. Alright. Now see over here, there are two types of nephrons which can be seen. First of all, the outer part is known as cortex, which is near to the capsule of the kidney, right? And then the inner part is known as medulla. But this medulla we are going to convert, or we are going to divide into two parts. What are the two parts? The outer near the cortex is going to be called as outer medulla, and the deep part is known as inner medulla. Now see over here, the shorter, you can say this nephron over here, most of its parts are present in the cortex, right? And the another nephron which is going to go deep into the medulla, which is known as juxtamedullary nephron. All right, why? Because most of its parts are deep into the medulla, which is going to be helpful to us for the maintenance of osmolarity. Now one more thing I want you to see over here, the composition or organization. See over here, first of all, this is the Bowman's capsule. From the Bowman's capsule, this is the PCT which is started over here. Then there is a loop of Henle and ascending limb of loop of Henle, and the end part of ascending limb of loop of Henle, and the beginning part or the starting part of the DCT is going to come in contact with this glomerulus, and this is what is going to form the juxtaglomerular apparatus. Same is going to be happened over here. Now if I ask you what is glomerulus made up of, it is made up of tuft of capillaries. So see over here, if this is the afferent arteriole, then there will be tuft of capillaries which are known as glomerulus, and then the efferent arteriole will start. Now see over here, this efferent arteriole, what will happen to that? It will keep on going towards, or it is keep on going to go and roam around the tubules. That's why these capillaries are going to be called as peritubular capillaries, right? And these peritubular capillaries are unable to go to the medulla, that is deep into the medulla. So we cannot leave that like this without any blood supply. So what we do is we give the branching of the peritubular capillaries, and the branches of peritubular capillaries, they are known as vasa recta, and then again the peritubular capillaries are going to go like this. All right, so please remember that. So let's talk about the cortical nephron and juxtamedullary nephron. Contribution, what do you think? Who are maximum? So please remember, 80 to 85% are the cortical nephrons, and only 15 to 20% are juxtamedullary nephrons. Loop of Henle of the cortical nephron are shorter. On the other hand, it is going to be longer in case of juxtamedullary. Peritubular capillaries, they are going to be present in case of cortical, but in case of juxtamedullary, we do have vasa recta. What about the blood flow? Blood flow over here and oxygen consumption is going to be maximum in case of cortical. Why? Because maximum blood flow is there in the cortex, right? In case of this is going to be comparatively lesser towards the juxtamedullary nephron. What about oxygen extraction? If you give more blood flow, of course, it is going to be lesser, and it is going to be much more as compared to the cortical nephron. Concentration of urine, in case of cortical, it is going to be normal urine which will be formed. In case of juxtamedullary, it is the concentrated hypertonic urine which will be formed in case of the juxtamedullary or by the juxtamedullary nephron. Please remember that. Now let's move on to the filtration, glomerular filtration membrane. It is made up of 3 layers, endothelial cells of the GC. GC means glomerular capillaries. First of all, glomerular capillaries are going to come, which will be made up of cells that are known as endothelial cells. Endothelial cells are going to lie on the basement membrane. So second layer is going to be basement membrane, and the third layer is going to have that into the Bowman's capsule, which are going to have the cells which are going to have the foot-like processes. That's why we call them as podocyte. So please remember, all of them, all these 3 layers are going to be lined by the negatively charged protein. The difference is that if they ask specifically which of the following has maximum amount of negatively charged protein, such as heparin sulfate, proteoglycan, sialoprotein, then the answer will be basement membrane. Now, please remember that. Now, if I, no need to remember, if just I tell you that what is the pore size of these, 70 to 90 nanometers will be the pore size of endothelial cells. That means the gap between 2 endothelial cells. The gap between 2 cells in the basement membrane is going to be 7 to 9 nanometers. On the other hand, it is going to be 4 to 14 nanometer in case of foot processes. So overall, if I talk about the minimum gap that is going to be present, what is this glomerular filtration membrane? It is nothing but a strainer, right? Chai ki channi, right? Strainer like condition. So suppose these are the 3 different layer, 1, 2 and 3, right? If I show you the minimum, they are going to be lying without any arrangement. So the smallest of the small pore, it can be ranged from 2.5 to 4 nanometer. 2.5 to 4 nanometer, that is the smallest pore possible. And the largest pore possible, that is 7 nanometer. So I'm going to take it as 2.5 to 7, but most of the books, physiology books, they are going to, write it as 3 to 7 nanometer. 3 to, or we can remember 3.5 to 7 nanometers. Alright. So please remember, I can write it as 4 to 7 nanometers also. Alright. So please remember that different books have different, you can say the effective pore size. That means the strainer, which is going to have the minimum pore and maximum pore. The articles also differ in that. No need to remember all those numbers. Just remember whichever is shorter than the 4 nanometer or 3.5 nanometer, then this is going to be easily filtered, isn't it? If the smaller particle is there, such as glucose, amino acid and other electrolytes, they are very small, they can easily cross the membrane. But if it is larger, the size of the substance is larger than 7 nanometer, such as RBC, WBC, macroglobulin, platelets, what will happen to them? Macroglobulins, platelets, right? All of them will never be filtered in the normal healthy person. Now, if the size fall between this, that is 3.5 or 4 nanometer to 7 nanometer, what will happen then? It depends on the charge. If the particles are anionic, that means negatively charged particle, what will happen? They will be repelled by negatively charged particles which are there lining the basement membrane and other parts of the glomerular filtration membrane. So they will be filtered the least, right? If it is a positively charged substance, see, cationic substance, they can be attracted and filtered very easily. Neutral substance, 50-50. All right. So if they give the chart like this, always don't get scared and see the x and y axis. Let's take the 26 angstrom size of the substances, and if it is positively charged substance, what will happen? See, this is going to have the maximum filterability, and the neutral molecule, I know that this is going to have 50-50, and if I take the molecule which is negatively charged, it is going to have the least filterability. So please remember, this is going to be, the C graph is of anionic substances, the B graph is of neutral. It is easier to understand or identify the neutral one, right? And the A graph is of cationic molecules. Why? Because they are attracted and they will be filtered much more. So please remember that. Okay, protein will never be filtered. Why? Because already negatively charged protein, they will repel the protein, especially the albumin. So if the person is having albuminuria, that means the negatively charged proteins or negatively charged substances which are lining the glomerular filtration membrane, they are defective. Please remember, albuminuria is abnormal, which is going to lead to the person into nephrotic syndrome. Alright, coming to the tubular transport. First thing first, PCT. Maximum reabsorption of all the substances, are going to occur in the PCT except the magnesium. Where the maximum reabsorption of magnesium occurs, it is going to occur in the ascending limb of loop of Henle. Maximum secretion of all these substances again, that is going to take place in the PCT except two things, that is potassium and urea. Potassium maximum, it is going to get secreted into DT, that means distal tubule, which consists of CD and DCT both. If both are not there in the option, go with the CD. Urea, what about urea? Again, it is going to get secreted in the loop of Henle. Now, in the PCT, we do have cuboidal epithelium, and that too with the brush border. You can see the brush border over here. Why we require brush border in this? Because if I straighten that up, I'm going to get maximum surface area for maximum secretion and maximum reabsorption. So please remember that. And what you are going to see over here is carbonic anhydrase, which is not only just present on the apical membrane but also present in the cell. What it is going to do? Remember, I need to reabsorb as much as buffer, that is bicarbonate, possible. But I don't have any transporter for the bicarbonate at the apical membrane. So how can I absorb the bicarbonate? What I'm going to do is, I'm going to secrete the H plus ion with the help of sodium hydrogen exchanger. The hydrogen is going to get combined with the bicarbonate, and it is going to form finally the CO2 and H2O with the help of carbonic anhydrase. Now this H2O can cross with the aquaporin, and CO2 is a gas that can also go inside the cell. Inside the cell also I'm going to have the carbonic anhydrase, which will reverse the reaction into H plus ion and bicarbonate. Now on the basolateral membrane, we do have these sodium bicarbonate co-transporters. With that help, I'm going to reabsorb that bicarbonate into the blood. So please remember that for the absorption of the bicarbonate, we are going to have sodium hydrogen exchanger and sodium bicarbonate co-transporter. We are also going to have SGLT. Which type of SGLT? Both the type of SGLTs are present, but remember, if both are not given in the option, go with the SGLT2. You have two kidneys, so in the kidneys SGLT2 are prominent. Why? Because only 10% are going to be SGLT1. Please remember that. Now coming on to the loop of Henle, it is going to do one major thing, that is counter current mechanism. Please remember, counter means opposite, current means flow over here, Now where these counter current mechanisms are present? Yes, it is present in the kidney because we are learning in the kidney, but please remember, in the other areas of the body also these counter current mechanisms are present. For example, kidney we are going to learn in the detail. For example, skin, let's say in the skin, why we require this counter current mechanism? Let's say that you want to generate the heat or release the heat or conserve the heat. At that time, in the cold or warm environment, depending on what is the environment, at that time I'm going to do the heat conservation or heat release with this counter current mechanism. So it is going to help me in the temperature regulation, right? Shunt vessel or vena comitants are going to be there. In the GIT, for the absorption of nutrients, I'm going to have this counter current mechanism. In the testes also, for the temperature regulation, we do have counter current mechanism in the males. In the retina, for the gas exchange, we do have, or for the gas diffusion, we do have this counter current mechanism. Not only that, in the lungs also, for the diffusion of gases, we do have this counter current mechanism. Now understand what is the aim of this counter current mechanism into the kidney. The only aim is to conserve the water, because our body is maximally made up of the water, right? For that, I need to make the concentrated urine. How I can do the concentrated urine? By making the medullary interstitium hypertonic. How can I do that? First of all, I require two parts for it. First of all, to create the hypertonicity into the medullary interstitium, I require multiplier. Why it is known as multiplier? The normal osmolarity of the plasma is 285 to 295 milliosmol per liter. But please remember, I'm going to take it as roughly 300. If I multiply it by 4, I'm going to get 1200 milliosmol per liter. So this multiplier is going to do the same. it is going to generate maximum osmolarity at the end, that is 1200 milliosmol. It looks as if it is multiplying the osmolarity 4 times. That's why we call it as multiplier. Now coming on to the loop of Henle and medullary CD. These are the ones which are going to help us out to generate that or create that hypertonicity. Now let's see how they are going to do it. First of all, this is the descending limb of loop of Henle. Please remember, descending limb of loop of Henle, it is going to drink the water. What I mean by drink the water? That means it is permeable only and only for the water, not for the solutes. On the other hand, the ascending limb of loop of Henle, it is permeable for salts, or you can say the solutes. Alright. Now what happens that since it is putting the water out of the tubule, the tubular fluid is going to be concentrated. So this is known as concentrating segment of the nephron, and the ascending limb is known as, limb of loop of Henle is known as diluting segment. Why? Because the tubular fluid inside the nephron, the fluid will be diluted because we are putting more solutes outside in the ascending limb or because of ascending limb of loop of Henle. Right? Now, understand, passively, only the descending limb of loop of Henle passively going to put the water outside. But remember, we are going to have the thin segment and thick segment of the ascending limb of loop of Henle. In the thin segment, what is going to happen is that only passively the sodium and chloride is going to come out. On the other hand, over here we are going to have the sodium potassium 2 chloride. Sodium potassium 2 chloride is the active transporter which is going to put the salts outside actively. So if I talk in total, that the water is going to be absorbed only passively, which is going to be much lesser as compared to active plus passive reabsorption of the salt, right? Or I can say solute. Hence, the osmolarity is going to be much, you can say, hypertonic in the medullary interstitium. Now, one more thing is going to help us out, and what is that? That is the medullary collecting duct, which is going to put the urea over here. Right? So it is also helping me out to have that hypertonic medullary interstitium. So they are going to create it. But there is one problem. What is the problem? You generated the hypertonic medullary interstitium, but in some time what will happen that in the next cycle more water will come out because of the salt in the medullary interstitium, and the medullary interstitium will get diluted. For that, what we are going to do, we are going to take the help of vasa recta. Vasa recta, what it is going to do, it is going to take the extra amount of water whichever is coming out of the nephron, and hence it will maintain the hyperosmolarity. So again, I'm telling you, first of all, we have generated the hypertonicity in the medullary interstitium. But in the next cycle, when the filtrate coming or the urine coming into the tubule, what will happen? More water will get out, and that will dilute the osmolarity, which we don't want. And hence, we are going to take the help of vasa recta, which will take the extra amount of water and put it into the renal vein finally. And that is why it is able to maintain the medullary interstitium hypertonic. So, they are going to ask you the direct question. First, who is multiplier? It is the loop of Henle and medullary collecting duct. In case they ask what is the exchanger, the exchanger is nothing but the vasa recta, which is able to maintain. So there are two parts. One is creation and second is maintenance. Creation is going to take place with the help of multiplier. And please remember, if you write two V's, that is vasa recta, right? So that is going to be the exchanger, which is going to maintain the medullary hypertonicity. Now let's talk about the thick ascending limb of loop of Henle, which is, again, if it is having any lesion, then it is going to lead to Barter's syndrome. And this is present at the ascending limb of loop of Henle, and even in the DCT, we are going to see what are the changes that are going to occur over here. First thing first, let's talk about the ascending limb of loop of Henle. For now, just let's focus on that particular area. We'll talk about the DCT in the next slide. Okay, so what is going to happen at the thick ascending limb of loop of Henle? First of all, See, there are 4 channels which you have to remember. First thing, at least 3 you have to remember. One more protein that you have to remember. First is the sodium potassium 2 chloride. Sodium potassium 2 chloride that is going to come in from the apical membrane, right? Then we do have the potassium exiting channel. That is nothing but the Rome-K channel. Now, what is this Rome-K channel? That is nothing but renal outer medullary potassium channel, right? That is going to be there. And plus we are going to have this chloride channel, which is nothing but the on the basolateral membrane. So see over here, whenever we are going to take the sodium inside, the sodium will go into the blood via the sodium potassium ATPase or Nokia pump, which is there everywhere. Okay, and this potassium is going to come here, plus this potassium is going to come here, and finally again that all potassium is going to go out into the tubular fluid via the potassium channels, that is Rome-K channels. Now, to activate this chloride is not going to get activated on its own. To open it or to activate it, I require a protein which is known as Barton protein. Okay. Now, there is a syndrome which is known as Bartter syndrome. If, first of all, there are 4 types of Bartter syndrome. If there is a lesion in the sodium potassium 2 chloride co-transporter, everything is going in a same direction. So that's why I can call it as symporter or co-transporter. So now what will happen if this is having any lesion, it is not working properly, I'm going to call it as Bartter 1, Bartter type 1, Bartter syndrome type 1. If the Rome-K channels are not working properly, I'm going to call that as Bartter type 2. And if the chloride channel has some problem, channel itself, not the Barton protein, channel itself, then it will be known as type 3. And if the Barton protein is having some problem, that is known as Bartter type 4. So there are 4 types of the Bartter syndrome. Type 1 is sodium potassium 2 chloride co-transporters lesion, or Rome-K. 2, 3 is chloride channel itself, and 4 is Bartter protein. One more thing you have to remember in the thick ascending limb of loop of Henle, that is the calcium and magnesium. Both are divalent cations. The reabsorption of divalent cations, that is going to happen with the help of paracellular transport. The paracellular transport of this divalent cations, that is going to happen in this TAL, that is thick ascending limb of loop of Henle via paracellular transports. Let's see the DT, that is the CD plus DCT. That is going to have 2 types of cell. First is principal cell and second is intercalated cell. Principal cells are going to do the movement of principal ions. So please remember P cells, principal cells, I cell, intercalated cell. Now I for I, remember acid, we have I. So acid secretion is going to take place via I cells. That is the main role of I cell. What about P cells, principal cells? So they are going to absorb the principal ion, that is sodium reabsorption is the role, and they are also going to secrete the potassium via, again, Rome-K channels are also going to be there. For the sodium reabsorption, they are going to use epithelial sodium channel, that is ENaC channel, epithelial sodium channel. Na is for sodium, alright. So epithelial sodium channels they are going to use for the sodium reabsorption. Now, talking about acid, acid can be excreted via the I cell, especially the alpha intercalated cell. Beta is going to secrete bicarbonate, that we are not going to go into detail because nobody is going to ask you that. Alright. Now, H plus ATPase, that means only hydrogen pump is there or hydrogen potassium pump is there. It is going to secrete the H plus ion in exchange of potassium. So that's why it is the hydrogen potassium pump. It is the pump. That means it is primary active. It is not exchanger. Exchanger is secondary active, right? This is the pump using the ATP on its own, right? It is not dependent on any of the gradient. So please remember that. Okay. Now, coming to the ADH and it's applied. First of all, ADH, if it is increased, so please remember, first thing first, if the ADH is increased, then it will lead to SIADH. What is SIADH? It is syndrome of inappropriate ADH secretion. But here we can remember I for increased, right? So ADH is going to increase. It is going to cause the SIADH. Now, what is the role of ADH? ADH is going to act on the CD more than DCT. That means it will act on both the cells, right, or both the areas. Now, what will happen after its action? The cyclic AMP, specifically if it is acting on the V2 receptor, what will happen? The cyclic AMP will increase, and via increasing the cyclic AMP, it causes the opening of aquaporin 2 channels. Actually, the aquaporin 2 are there in the vesicle. These vesicles are going to get exocytosed on the apical membrane. The aquaporin 2 will be inserted on the apical membrane. And hence, the water reabsorption is possible into apical membrane, and from the basolateral membrane, aquaporin 3 and 4, which are constitutively open, that means always open, they are also going to be there, and hence the water permeability is going to be increased and the water reabsorption is increased via the ADH. Anti-diuretic hormone. Diuresis means you are excreting more and more water, which is anti-action. That means anti-diuretic hormone is doing the opposite action to that of the diuresis. All right. Now, if it is more, what will happen? More will be the water permeability, more will be the water reabsorption. That means the cells are taking the water from the urine and putting into the plasma. So urine will have lesser water and urine osmolarity will increase. Why? Because solutes will be more. On the other hand, they are putting that water into the plasma, so the plasma will be diluted. Hence, the plasma osmolarity will be lesser. Urine will be concentrated. Please remember in the SiADH, right? So, low volume, concentrated hypertonic urine will be released in the SiADH. The maximum osmolarity it can reach up to is 1200 milliosmol per liter. Exact opposite scenario is going to happen in the diabetes insipidus. Please remember, be that any type of diabetes mellitus or diabetes insipidus, the patient will come to you with a complaint of polyuria and polydipsia. Dipsia means the patient will keep on feeling thirsty. So, he is going to drink a lot of water and he is going to go to the washroom for the longer time, right? Or many times, right? So, diabetic insipidus, in this, the reason is ADH is deficient or ADH is completely absent. Of course, ADH is not there, so permeability will be decreasing, water reabsorption is decreasing. That means we are losing a lot of water into the urine. So, urine will be now diluted and plasma will be concentrated. So, urine diluted means urine osmolarity is going to decrease and the plasma osmolarity is going to increase, right? So, plasma osmolarity increases, urine will be high volume, diluted hypotonic urine will be there, and the minimum osmolarity it can reach up to is 50 milliosmol, and the range is 50 to 100 milliosmol per liter. Let's move on. If the ADH is present and ADH is absent, only the distal tubule is going to be affected, especially the medullary and cortical collecting duct and then the DCT. Let's see how the tubular fluid is going to change its tonicity. Let's say you have, this is Bowman's capsule, then this is PCT, then we have loop of Henle, right, and then there will be DCT, and let's say there is collecting duct. Now what will happen is, as soon as the fluid is or tubular fluid is moving from the PCT, what will happen? There will be reabsorption of water also and there will be reabsorption of salt also. So there will be isotonicity which is going to be maintained. But as soon as it is going to come into the descending limb, suddenly the water is going to go out, and that's why what happens? Of course, the osmolarity will shoot up in the tubular fluid, right? Now what will happen is that if the fluid moves through the ascending limb of loop of Henle, the salt is going to come out, and that's why. And please remember, we have discussed that more salt is going to come out. Why? Because passively as well as actively we are putting out the salt from the urine into the plasma. All right. So hence the osmolarity is going to decrease. Now just keep this in mind that high water intake and low water intake, if we say that the water intake is normal or low, then what will happen? If the ADH is present, it is going to reabsorb more and more water from the urine, and hence the urine will be concentrated. But if the ADH is not there, what will happen? More and more urine will be formed. Why? Because more and more water will be lost into the urine. Just remember, if the ADH antidiuretic hormone is present, it is going to be concentrated. If ADH, which is antidiuretic hormone, which is also known as arginine vasopressin, that is also one of the name of it. If it is absent, then it is going to be diluted. The urine will be diluted. Coming on to the TMG, which is the transport maximum, or if I'm writing T max is transport maximum, if it is written as TMG, the transport maximum or tubular maximum for the glucose, right? And we are going to see what is renal threshold. Let's see. Maximum transport rate of a substance per unit time is known as Tmax, right? If we are calculating for that Tmax for the glucose, then it will be called as the TMG. Now, how much it is? It is 375 mg per minute. What is it? It is the maximum glucose transport possible that we are expecting. But in reality, that is not the value. The value is 180 to 200 mg per minute. So there is a huge gap between the reality and expectation, and whenever there is a gap, that gap is known as splay. Since this is happening in the renal system, we call that as renal splay. Alright, so this is nothing but the renal splay. Why this happens? The renal splay takes place because of the heterogeneity of the nephron. Heterogeneity of the nephron means not all the nephrons, they are active all the time, and not all the nephrons work at Tmax. Okay, so some may have lesser Tmax, some may are not working right now, right? So that is the two reasons for the heterogeneity of the nephron. Now, there is something known as a tubular load or filtered load. What is tubular load or filtered load? For the tubule to reabsorb or secrete something, how much load you are putting. Of course, we are giving the glucose for reabsorption. So, how much load is coming towards the tubule for the reabsorption of the glucose? That is nothing but the filtered load or tubular load, right? Why it is called as filtered load? Because it came via the filtration. Alright. Now, how to calculate that? We know that what is the GFR and we should know what is the plasma concentration. Multiply it and you are going to get the filter load or tubular load. GFR into plasma concentration. That is the formula for calculation of tubular load. Now, this is the graph for renal splay. Please remember, please remember, all the graph will not come to you, right? Don't get scared, right? Only one graph will come to you. Just how to identify it. They are going to ask you what is it. Okay, so let's say somewhere this graph is given. So see, ideal graph is the dotted one, right? And the actual graph is the red one, right? Now what you can see is till here no glucose should have come into the urine, but that doesn't happen. The glucose, plasma glucose started to come into urine here only, right, instead of here. So this gap that you are seeing, I'm highlighting it. This gap, what we are seeing here, the triangular gap, is nothing but renal splay. They will mark the area and they will ask you what is it. You have to say that this is the renal splay. Now we can see we expected that the excretion will start over here at the plasma concentration of 300, but it started at 180 or 200 itself. So this triangle again is nothing but your, what is it? This triangle is again the renal splay. This is again the renal splay. All right. Again, we expected the reabsorption to occur like this, but even before that, the reabsorption started to decrease. So this triangle is also the renal splay. No matter what graph, what type of graph they are going to give, this is going to be the renal splay. Right? Renal threshold, that means how much it is able to absorb at one particular time, right? So renal expected is going to be different and actually is going to be different, all right, because of which the renal splay is going to be there. Now let's talk about the clearance. We know that we are going to have the Bowman's capsule. Let's say this is the Bowman's capsule, and let's say this is the afferent arteriole, glomerulus, efferent arteriole, peritubular capillary, afferent, glomerular capillaries, efferent arteriole and peritubular capillary. Finally, there will be multiple tubular systems which are going to come across, and finally we are going to form the urine here. Let's assume all the tubules are completed and we are forming the urine over here. Now, if there is one substance which is getting cleared from the plasma, whatever renal plasma flow is going to come, let's assume that these are 100 molecules. Out of that, 20 molecule got filtered and 80 molecule went forward, right? There is one substance which is only and only filtrated, that is not going to get reabsorbed or secreted. No reabsorption, no secretion, only filtration. The name of the substance is inulin. Hence, it is most accurate for GFR estimation. We can estimate the GFR with the help of inulin. The thing is, inulin has to be given exogenously. It can have its own complication also, right? And we have to wait till the patient is going to get his urine, right? So please remember, it is not most common method. Rather, one product which is produced by the muscle metabolism, that can also come into the urine. The thing is that yes, it is going to get maximally filtered, that is similar like inulin, but out of that 80 molecule, 1 or 2 molecules can come into the tubular fluid via secretion. So it is not that accurate, but again, we can apply the correction factor and we can measure the GFR. So what is that substance? That substance is creatinine. Creatinine is the substance which is also used for GFR estimation, and this is most common. Why it is most common? Because it is endogenously produced and we don't have to wait. We just ask the patient to give the 24-hour urine sample. Alright, now let's talk about the next thing, that is filtration plus complete secretion. Let's say instead of this one molecule, all the 80 molecule, out of those 80 molecules came back into the tubule. So how many molecules you will find into the urine? Of course, all the 100 molecules you will find into the urine. That means complete secretion has been occurred. Please remember, this should be in the physiological limit. If that crosses physiological limit, the proteins which are secreting that substance, they are going to get saturated and the complete secretion will not occur. That is beyond the physiological limit. What is such substance? That substance is PAH. So 100 molecule came via the renal plasma flow and 100 I got into the urine. I can say that its clearance, that is para-aminohippuric acid, its clearance is equal to renal plasma flow. So for the renal plasma flow estimation, I can use the para-aminohippuric acid. Now, if I say instead of let's say secretion, some substance was there which got completely reabsorbed, right? Out of these 20 molecules, 20 out of 20, all the molecule got reabsorbed back within the physiological limit only, right? What will happen? No molecule will come into the urine. I have some substances which I require for the energy, that is glucose and amino acid, which will be 100% reabsorbed, that is glucose and amino acid. But once you start increasing the plasma load beyond its capacity, of course, they will come into the urine. Why? Because again, the SGLT molecules, they are going to get saturated, and that's why the glycosuria can start beyond the physiological limit as you will increase the plasma concentration. Now, how to calculate the formula? Please remember, there is a formula, that is UV by P. What is UV by P? That is, U is the urinary concentration of the substance. P is plasma concentration of substance and V is urinary flow rate or volume of urine or urine volume. Okay, so I'll just write or over here, or urinary volume. Okay, flow rate or flow volume. Okay, urine volume. Now, if I say that I have to order them out, that which is secreted more or which is going to come more into the urine, then maximum clearance will be of pH. Then comes the creatinine, because it is little secreted also. Then the inulin, urea will be reabsorbed back. Some sodium and water will be reabsorbed back. That is 90 to 99% of the sodium to water, depending on the need of the body, that will be reabsorbed back. And the glucose and amino acid usually 100% reabsorbed back. So their clearance is going to be minimum in the physiological condition. So see, they are going to give such kind of graph. One thing you have to apply your brain. Please remember, inulin is never reabsorbed or secreted. It is going to be straight, one simple straight line. It is always and always going to be inulin. So it looks like I also, right? longitudinal eye, है ना, vertical करो, that will be inulin. So please remember the straight line is always and always inulin. Then first of all, there will be 100% reabsorption of a substance. If you increase the plasma level, then only this is going to increase into the urine. That means the clearance will start to occur after a certain level, that is nothing but the glucose and amino acid. Now see over here, usually 625 ml is our what thing? It is renal plasma flow, and equal to the renal plasma flow is our PAH. But as we increase the plasma level, it will go beyond the physiological level, and hence what will happen? The saturation will start to occur, and it takes some time to secrete the pH, right? And hence beyond the physiological limit, its clearance will start to decrease. If I have to draw the creatinine, it will look something like this. It will be little more, the clearance of the creatinine, it will be little bit more than the inulin, okay? Next, the GFR regulation. GFR will be having the auto-regulation. That means you increase, as we increase the renal blood flow, what will happen to the glomerular filtration? That will also increase accordingly or proportionally, okay? It is maintained from 90 mmHg to 210 mmHg, but it is given in the, or the experiment is done in the dog, not in the human being, alright? So it is maintained constant. That is known as auto-regulation. There are three mechanisms. First is the myogenic mechanism. Myo means muscle. So as the BP increases, the stretch receptors on the afferent arteriole, they will be active. They will get stretched. That means they will have more renal plasma flow, and the GFR increases because hydrostatic pressure will also increase into the glomerular capillary. But I want to maintain it. So how we can maintain? What happens is, as soon as the stretching of the afferent arteriole occurred, there will be opening of calcium channel because of the stretching. And because the calcium will come into the smooth muscle of afferent arteriole, we know wherever the calcium is going to increase in the muscle, that will cause constriction. So hence the afferent arteriolar constriction will take place, and the GFR will be decreasing back to the normal. So that is how it is auto-regulated with the myogenic mechanism, muscle mechanism, alright. The second thing that is going to regulate is the RAS system, which is going to get activated with the help of this JJ apparatus. JJ apparatus has three different components. First is the juxtaglomerular cells, that means which are near to the glomerulus. What they are going to have, they are going to contain, if you can appreciate over here, there are going to be small granules which are going to be present in these JG cells. What are these granule contain? These granule contains what thing? They are going to contain a renin. Renin will be there, and once the renin is secreted, what will happen? Renin is secreted, that will activate the RAS system, that is nothing but renin angiotensin aldosterone system, and that is going to maintain the blood pressure as well as the renal plasma flow. Alright. Then there is something known as macula densa. Who is telling the renin to get released from the granular cell? It is those macula densa cells which act as a chemosensors. Chemo means they must be sensing some chemicals. What are the chemicals which are sensed by this chemosensors? That is nothing but the sodium and chloride level. How that happens, we'll see that. First of all, just now remember that sodium and chloride will be sensed by the macula densa cells. Now what will happen? See over here, these are the modified epithelial cells which are known as macula densa cells. Right? Now they sense more sodium chloride and they will produce signal via adenosine. How? We'll see in a minute. And they will give the signals, or they will activate this JG cells. Alright, so please remember that. The third component of JG system is the Lassus cell. It has nothing to do with the autoregulation. They are just anti-inflammatory cells. And what are these cells? These are nothing but extraglomerular messenger cells, which are also known as Lassus cell. So another name for the Lassus cell is nothing but extraglomerular messenger cell. Alright, please remember that. Next, moving on to the TG feedback. What does TG feedback stands for? It stands for tubuloglomerular feedback. So the feedback is going to come from the tubule towards the glomerulus. That's why it is called as tubuloglomerular feedback. Just now we saw that whenever the GFR is going to increase, what will happen? More will be the filtration. When more will be the filtration, more NaCl will be filtered. That means more the macula densa cells will be activated, and more macula densa cells will be activated. That means they will start absorbing more and more sodium and chloride. In that process, we are going to utilize a lot of energy. That is nothing but ATP will be converted into ADP, AMP, and finally adenosine. So more and more adenosine will be generated. So that adenosine will travel towards the afferent arteriole, and that will increase the calcium into the smooth muscles of afferent arteriole. Adenosine is increased in the macula densa cell, that is going to travel towards the afferent arteriole, and that is going to cause the release of calcium in the afferent arteriole, and that will lead to the constriction of arteriole, and that will cause decrease in the GFR. So the tubules are going to give the feedback towards the glomerulus that too much NaCl is coming, reduce it, and that's how it is going to work. So that's why it is known as tubuloglomerular feedback. Alright. Next, afferent and efferent arteriolar constriction. It's very, very simple. So see, first of all, that I'm going to have the Bowman's capsule. I'm going to draw the Bowman's capsule over here, right? And the Bowman's capsule here also. Let's draw it. Okay, and then I'm going to have afferent arteriole, glomerulus, efferent and peritubular capillary, afferent arteriole, glomerulus, efferent arteriole, peritubular capillary. Again, I'm drawing that same thing here also, so that we can understand it better. Now let's talk about the afferent arteriole. Afferent arteriolar constriction, that means when you are going to narrow the lumen, of course, lesser renal plasma flow will come towards the glomerular capillary, hence the hydrostatic pressure will reduce. Right? As you increase the resistance in the afferent arteriole, you are constricting the inlet. So less renal plasma will come towards the glomerular capillary, less will be the GFR. The GFR, of course, is going to decrease. So see over here, it is directly proportional. Both of them are going to decrease. So if we increase the afferent arteriolar resistance, what is going to happen? See over here, first of all, the GFR is going to reduce. Why? Because there is decrease in the renal blood flow. So renal blood flow is also going to reduce, and renal, this thing, glomerular filtration rate is also going to reduce. But what do you mean by renal plasma flow actually? Renal plasma flow is not something that is coming in the glomerular capillaries. Renal means which is going towards the nephron, that is tubules, right? From the peritubular capillary. We are going to denote how much blood is coming into the peritubular capillary as renal plasma flow or renal blood flow. So see over here, you call it as renal plasma flow, or you add the blood cells, that is known as renal blood flow. So now if I constrict the efferent arteriole, mild to moderate constriction, now what is going to happen? Of course, in the front I'm having pressure more, right? More resistance. So what is going to happen initially is that the hydrostatic pressure will increase and the GFR will increase. But. If it is 3 times more constriction, that means the lumen is narrowed to its 1/3, you can say, diameter or radius, then what will happen? The proteins will not be able to cross there. Hence, the oncotic pressure will increase. And I told you that the oncotic pressure is holding on pressure, right? So it will hold on more water, and hence the GFR actually decreases. GFR actually decreases, right? What will happen to the renal plasma flow? See over here, I told you that the renal plasma flow means how much blood is coming towards the peritubular capillaries. No matter you do the mild to moderate constriction or severe constriction, of course, the renal plasma flow is going to decrease only. So see over here, first of all, it is very simple about the renal plasma flow. No matter you do mild, moderate or severe constriction, it is going to decrease. As you increase the resistance, the plasma flow or blood flow is going to decrease. But in case of glomerular filtration rate, see over here, first of all, due to increase in the hydrostatic pressure, what will happen to the GFR? GFR will increase, and later on, because of the increase in the oncotic pressure, the GFR will reduce because the proteins are not able to go forward towards the peritubular capillary. The same thing is given over here. If you do the afferent arteriolar constriction, the renal plasma flow as well as the glomerular filtration rate, that means both are going to decrease, the numerator as well as denominator. If I have to calculate the fraction, that is filtration fraction. How can I calculate? The formula is GFR upon RPF or RBF, that is blood flow or plasma flow, right? If I decrease both the things, filtration fraction will normal, right? If I increase both the things via dilation of the afferent arteriole, again both the things are going to be increased, so the ratio will remain normal. In case of efferent arteriolar constriction, it depends if we are doing the mild to moderate or severe constriction. What happens? See over here, first of all, in the mild to moderate constriction, the renal plasma flow is going to decrease and the GFR is going to increase, hence the filtration fraction will be increased. But in the severe constriction, the GFR will also decrease, hence what will happen? The filtration fraction is also going to decrease. Now, when I talk about the dilation, what will happen is that the RPF is going to increase, right? Renal plasma flow or blood flow is going to increase, but the GFR will decrease, hence the filtration fraction is going to decrease. Let's come on to the GFR. Now, how to calculate this GFR? There is a formula to calculate the GFR, that is KF. What is KF? KF is filtration coefficient. How much is the KF or filtration coefficient? It is 12.5 ml. 12.5 ml per minute. Now, let's calculate how much is the net filtration pressure. Now, nobody will ask you to calculate GFR, but definitely they will ask you, the examiners will ask you to calculate net filtration pressure. Now, we have learned that there are two types of pressure. First is the hydrostatic pressure. Let's understand via one capillary over here. If I say that the hydrostatic pressure has been increased in this, so it is the pushing pressure. It pushes the water away from it. No matter where it is present, it is going to push the water away. So if I say that in the capillary, the hydrostatic pressure is more, it is going to increase the filtration out of the capillary. If I say that hydrostatic pressure is more over here, it is going to oppose the filtration of the fluid out of the capillary. If I say oncotic pressure, O for oncotic pressure, and in the proteins also we do have O. So please remember, oncotic is because of the protein, and protein loves the water, so they will hold on to the water. It is the pulling pressure, right? HP is the pushing pressure, OP is the pulling pressure, right? If the OP is higher, the filtration will be decreased out of the capillaries, and if the OP is higher here, they will attract more water and the filtration will increase. So how to calculate net filtration pressure? There is a formula. It's easy. I'll tell you how to write this formula. Write HP minus OP minus HP minus OP. Now, what is this HP-OP? HP is hydrostatic pressure, OP is oncotic pressure. Put the second HP minus OP into the bracket. And we know as soon as the blood is going to come towards the capillary and it is going to come towards the renal system, it is going to first come in the glomerular capillary, and then it is going to, some part of the plasma will get filtered into Bowman's capsule. So first comes the glomerular capillary, so I'm going to write GG over here, and then comes the Bowman's capsule, so I'm going to write the BB over here. That means Bowman's capsule. Okay, formula is done, right? HP minus OP minus HP minus OP, put that into bracket, then write GGBB, that is hydrostatic pressure in the glomerular capillary minus oncotic pressure in the glomerular capillary minus hydrostatic pressure in the Bowman's capsule minus oncotic pressure in the Bowman's capsule. We never filter the protein in the healthy person, and that's why, hence the OP in the Bowman's capsule is always going to be 0 in the normal healthy person. Right? If we calculate the normal values via putting the normal values, then it will be 60 minus 32 minus 18 minus 0, right? So it will become 28 minus 18, that will become 10 mmHg, and this is ml per minute. So how much is the GFR? It is 10 into 12.5, that is going to be 125 ml per minute per mmHg of pressure, right? So please remember that. Okay, let's move on. Let's move on to the next thing, that is acid secretion and acidification. If I say that there are two beakers like this, so and I add 20 molecule of, let's say, acid over here and 20 molecule of base over here, what will happen to the pH? pH will still remain normal. Why? Because I added equal amount of acid and base, right? Same is going to happen in case of the PCT. right? And at the CD and DCT, what is going to happen? I'm going to only put 10 molecules of acid, but I'm going to put very, very less base. That is, let's say 4 to 5 molecules of base. Now, I'm pouring less amount of acid, but less amount of buffers are available. So yes, the pH is going to decrease, and because of the change in the pH, we are going to say that this fluid in the beaker B is acidified because it is going to decrease the pH of the solution. Same funda is applied. So suppose this is the PCT and suppose this is the CD and DCT. Right? So what is going to happen in the PCT? Maximum acid secretion is going to take place in the PCT, but there is no change in the pH. Why that happens? Because maximum buffers will be utilized, or maximum buffers will be available to neutralize the pH. So there will be no acidification, but lesser secretion occurs at the DCT, but the acidification occurs at the CD more than DCT. Why? Because less buffers are available. Least or less buffers are available. Right? So that's why the pH is going to decrease, and that's why it is called as the acidification that is going to take place in the distal part. What is the normal pH of the urine? It is 6 to 8. And what is the minimum pH possible of the urine? That is the 4.5, which is also known as limiting pH. Below that, the pH of the urine will never go. Alright. Now, what are the buffers that are present in the urinary system? Main buffer and the most important urinary buffer is going to be always and always, it is going to be bicarbonate. What is the inducible buffer? It is none other than ammonia. Inducible means, so which is newly produced, and that is nothing but the ammonia. Right? So please remember N for N. That is, the inducible buffer is nothing but the ammonia and ammonia only. But these cannot be measured in the laboratory. So the only titrable buffer in the urine at which is secreted main at CD, that is going to be phosphate. That is going to be phosphate. And the one more thing that we have to learn in the renal system, that is nothing but cystometrogram. What is cystometrogram? It is the pressure volume curve that we are going to measure of the urinary bladder. Now what happens is, as the urine started to build up into the, let's say urine is getting filled up into the urinary bladder, what is going to happen? Slightly the pressure is going to increase and the volume is also going to increase. But after some time, what will happen? Yes, the volume is increasing, but pressure is not increasing that much. Right? And this phase, what happens is, yes, the pressure slightly increases first of all, but it will decrease after some time. The pressure is going to increase temporarily, but again it is going to decrease after some time. And these kind of waves are going to come, but overall average pressure is not going to change. How this is possible? This is possible because of the Laplace law is applicable at this phase. Right? What is the Laplace law? Laplace law is P is equal to T upon R. So please remember, as we are increasing the tension via putting lot of fluid into the urinary bladder, what happens? This is a smooth muscle. They don't have titin, which is giving the muscle elasticity. If they don't have titin, they have the property of plasticity, right? And this question has been already asked, that the straight line comes because of plasticity or adaptability of the smooth muscle. So what happens? Yes, the tension increases temporarily, but the smooth muscles will adapt to the new radius. So radius is also going to increase. And if you increase the denominator also, the pressure remains constant, right? So that is nothing but the Laplace law, which is going to be applicable over here. The Laplace law will be applicable. These are the micturition waves which are shown in the dotted line. Please remember, if you want, you can go and void into the washroom. But if you don't want, or the situation is not appropriate, the social situation is not appropriate, you can hold the urine also. But it again is going to have the limit, right? After the limit, the urge will be so stronger, the pressure will continuously rise, and hence we have to go and void. That is urination. So that is how we have completed the renal system RR also. So let's do the homeostatic points. Maximum blood flow in the kidney. How much it is there? It is 1200 to 1250 ml per minute, right? That is 20 to 25% of the cardiac output. Maximum blood flow that is going to occur per 100 gram per minute is for the kidney. Types of nephron, which is going to do the concentration of urine, that is none other than the juxtamedullary nephron. Right? Then transport, maximum transport of substances that is going to occur in the PCT, be that the reabsorption, be that the secretion, even the water, whether the ADH is present or not present, ADH is going to cause only 10% of the reabsorption. Maximum reabsorption, that is 60 to 70% of the reabsorption of water is always going to occur in the PCT. Whether the ADH is present, not present, doesn't matter. Maximum reabsorption, if they ask, then this is going to be occur in the PCT. The CC multiplier and exchanger. Multiplier is nothing but the loop of Henle and the medullary collecting duct, right? And exchanger is nothing but the vasa recta. Vasa recta is going to maintain the hypertonicity. On the other hand, LOH and MCD is going to generate it. Filtration and complete secretion, that is going to occur in case of para-aminohippuric acid, and its clearance is going to be equal to renal plasma flow. You can remember P for P, right? Renal plasma flow. If you want to measure that, you can use the para-aminohippuric acid. Then what is renal's play? There is a difference between expected renal threshold and the real or actual renal threshold, right? The difference between these two is known as the renal play. The GFR is calculated as coefficient of filtration into net filtration pressure. How to calculate net filtration pressure? HP minus OP minus HP minus OP. And I know that the glomerular capillary comes first, so G, and then comes the Bowman's capsule. So then I'm going to write B over here. And that's how you can calculate it. Now we will discuss about the endocrine system, classification of the receptor. Now understand, classification can be based on many things. First thing is depending on whether the hormone is lipid soluble or water soluble. If it is a lipid soluble such as thyroid, steroid, and the vitamins such as the lipid soluble vitamins such as A, D, E, K, then definitely it is going to have the intracellular receptor. If it is a water soluble, you yourself can think about it that if it is a water soluble, it will not be able to cross the cell membrane. If it is not be able to crossing the cell membrane, of course we have to keep the cell surface receptor for them because they will not be able to come inside the cell. Alright, so with that being said, let's move on. The another classification of the hormone or the receptor that depends on the different hormones. So let's see. First thing first, nuclear receptor. Intracellular, if I draw the cell over here, see, if this is the cell and this is the nucleus, assume this is the nucleus, then if the substance is lipid soluble, either it is going to come in and either it is going to bind to the receptor which is there in the cytoplasm, or let's say this is the DNA, RNA, whatever it is, then if it doesn't like to bind in the cytoplasm, it can directly bind into the nuclear receptors, right? So these are the intracellular receptor. Now, which are the hormones which are going to work through the nuclear and nuclear only? So remember the mnemonic nuctad. What is nuctad? Nuctad is nuclear receptors are there for 3 hormones, or you can say thyroid is the proper hormone, and there are 2 vitamins which act as the hormones that are nothing but vitamin A and vitamin D. That is nuctad. Nuctad means nuclear receptors are there for the thyroid, vitamin and vitamin D. Cyto. Please remember cyto is for aldo. What is cyto-aldo? Cytoplasmic receptors are there for the aldosterone. That is one of the mineralocorticoid, the major mineralocorticoid. Coming on to the both, if the receptors are there for the hormone, they can act on the nuclear receptors and they can act on the cytoplasmic. If both the receptors are not there in the option, go with the nuclear, because most of the time these hormones are going to act through the nuclear, but they can act through the cytoplasmic receptors also. Right, so nuclear receptors. So please remember sex steroids, all the sex steroids, they are going to act through this sex steroids such as estrogen, progesterone, testosterone, right, all those hormones. Plus there are glucocorticoids such as cortisol, corticosterone, all these hormones are also going to act through, yes please, they are going to act through both nuclear and cytoplasmic. If both is not there in the option, you're going to mark the nuclear first. All right, let's move on. If they are not lipid soluble, then they are going to act on the cell surface receptor, which is going to be outside of the cell, of course, right? First thing first, remember tyrosine kinase. Cytokine kinase also has tyrosine kinase, but the thing is, only tyrosine kinase if we talk about, then you're going to mark two hormones, that is nothing but insulin first and the growth factors. There are different types of growth factors such as the vascular endothelial growth factor, nerve growth factor, fibroblast growth factor, erythropoietin growth factor, so on and so forth, right? So I'm just writing etc. Brain derived growth factor, all these things. Then if I talk about cytokine receptors, they can act through the tyrosine also, because cytokine per se has the tyrosine in it. Okay, so you have to remember three hormones over here. First of all, you all know that the prolactin and the growth hormone, prolactin growth hormone, with that we do have leptin. Please remember, all of these are going to act through the cytokine receptor and they are going to act through a pathway. These are the receptors which are cytokine receptor. The pathway that they are going to act through is JAK-STAT pathway. Janus kinase, the signal transduction and activation of transcription is the JAK-STAT pathway with which they are going to act. Now, I don't think so that they will ask you about the serine kinase, but still we should know that the Mullerian inhibitory substance and the activin, these are the two hormones which are going to act through serine kinase. So this is the receptor classification. Now you will ask me, what about the rest all? Rest all hormones are going to act through GPCR protein. GPCR is the protein which is going to pass the membrane 7 times, right? And that's why it is known as 7-pass receptor, or it is going to go across the membrane. That's why we call it as transmembrane receptor. We'll see a diagram just in a minute or so. Now, remember, they are whichever hormone are going to act through the GPCR protein, those hormone will be called as first messenger or primary messenger, and in the cell, they are going to activate some mechanism depending on what type of hormone it is, and they are going to produce secondary messenger. So depending on secondary messenger, we are going to identify, yes, it can be this hormone, right? Or that particular hormone is going to act through a particular secondary messenger. So let's see. Now understand, most of the hormones are going to act through, whichever are going to act through the GPCR protein, they are going to act through cyclic AMP. So we are going to do the smart study. We are not going to remember all the names which are going to act through the cyclic AMP. Rather, we will discuss about the cyclic GMP wala hormones and the IP3-DAG hormones, and then rest all are going to come in the cyclic AMP, of course, right? So cyclic GMP, please remember, the hormones which are responsible for dilation or relaxation, they are going to act through the cyclic GMP, such as, let's say, the nitric oxide or ANP. You can write BNP, CNP also in this. Nitric oxide is universal dilator. Wherever it is going to go, it is going to cause dilation. Now, the typical example they have asked about is the erectile dysfunction or sildenafil directly. That is going to act upon the vessels and that is going to increase the NO. And they have asked about the secondary messenger, that is going to be cyclic GMP. What about ANP? Atrial natriuretic peptide. This atrial natriuretic peptide, natriuresis, this will cause natriuresis. When it will cause natriuresis? Whenever there is a hypervolemia, the venous return towards the right atrium is going to increase. Whenever the venous return towards the right atrium is going to increase, it is going to release this ANP. That will cause natriuresis. Natriuresis we caused because we know that wherever sodium goes, water follows. So water is also going to go out, and the hypervolemia, that was the problem that will be solved because we causing the more and more water excretion also via sodium excretion, right? Now, coming on to the IP3-DAG. Please remember, IP3-DAG, they are going to cause increase in, especially this IP3 is going to cause increase in the calcium. and that too in the muscle. We know that if the calcium is increased in the muscle, there will be contraction that is going to happen. So remember, all the contractile hormones, they are going to act through the IP3-DAG. There are some exceptions also. Of course, it is a medicine that we are learning, right? That is not going to be that easy, but we'll try to make it easy. Now, please remember, first hormone is oxytocin. We know that it is going to cause the contraction of uterus or the myoepithelial cells of breast or the vas deferens. So, of course, it is contractile. Then come on to the vasopressin. The name itself telling us that this is pressing the vessels. That means compressing the vessel or contracting it. So, that is also going to act through it. Then this is known as ADH, but please remember, the ADH should act through V1 receptor, then only it is going to act through the IP3-DAG. If it is acting through V2 receptor, then it will come under the cyclic AMP. Coming on to the adrenergic receptors, adrenergic receptor, if especially the adrenaline and epinephrine, they are acting through alpha 1, then that will come under the IP3-DAG. If they are acting through beta 2, then it will come under the cyclic AMP. Then coming on to the acetylcholine, if it acts on M1, M3 and M5. I'm just writing like this, M1, 3 and 5. If that is acting on M1, M3, M5 receptor, then this is going to act through the IP3-DAG. Like for example, in the stomach, it acts through the vagus nerve, is going to release the acetylcholine, that is going to act through the IP3-DAG, right? Then coming on to the angiotensin 2. That is also going to act through the IP3-DAG. Now, there are some exceptions. Now, exception means these are the hormones which are non-contractile but act through the IP3-DAG. What are those? Those are GnRH, GHRH and TRH. Please remember that if they ask about thyroid releasing hormone, then that will come under IP3-DAG. If they ask about thyroid stimulating hormone, that is going to come under cyclic AMP. If they ask particularly about T3, T4, then it will come under nuclear receptor. Alright, the three of it is going to be different. Now let's talk about the sequence that it is activating. First of all, look at this diagram. One by one, we will clear everything. Now, if I show you the GPCR, why it is known as GPCR, that is G protein coupled receptor, because it will be attached to the GTP or GDP, right? So that's why it is known as G. Okay. So see over here, this is the GPCR protein. Count with me, 1, 2, 3, 4, 5, 6, 7. So it is crossing the membrane 7 times. That's why it is known as 7-pass receptor. As soon as the hormone is going to sit on it, let's say this is the hormone which is going to generate the cyclic AMP as the second messenger into the cell. Now what will happen in the cyclic AMP pathway? Look over here, there will be heterotrimeric protein which will be attached to this GPCR protein whenever the hormone is going to come, right? Now, whenever the hormone is going to come, one more thing is going to take place, that this alpha will be attached to GDP, that is the guanine diphosphate at the resting condition when the hormone is not there. As soon as the hormone is bound to the GPCR protein and these heterotrimeric proteins are attached to it, now this GDP will be converted to GTP, that is guanosine triphosphate. Now, once it is converted to GTP, this alpha will be activated. Now, this activated alpha will go towards the enzyme which is there in the cell membrane, which is embedded there in the cell membrane, and activate that enzyme. And what is that enzyme which got activated? That is nothing but adenylyl cyclase. So please remember, first of all, hormone comes, which is the primary messenger which will activate the GPCR protein. As soon as the GPCR protein is activated, the alpha is going to get activated and the enzyme will be activated. As soon as the enzyme is activated, what will happen? This ATP will be converted into cyclic AMP. Of course, that is the role of the adenylyl cyclase. So please remember, the secondary messenger is produced. After the enzyme, the secondary messenger is produced, and that secondary messenger will go and activate a particular protein kinase, and those protein kinase are going to do the phosphorylation. You can see over here, right? And that's how it is going to give the response. So you have to remember only 3 things. First is the enzyme will be activated by activated alpha. That will create the secondary messenger inside the cell, and that is going to generate or activate the protein kinase. Which protein kinase? Of course, it is the cyclic AMP which is activating. So protein kinase A will be activated. All right. So with that diagram, we'll come back to this question. If I ask you, what will be activated first? We know that the protein kinase is going to get activated at the last, because that is going to give me the cell response via doing the phosphorylation, right? And the enzyme will be activated first, right? And then the secondary messenger will come. Secondary messenger comes at second place after activating the enzyme, right? So the answer over here is option C. Let's move on to the next pathway, that is cyclic GMP pathway. Now, only small change you have to do, or you have to remember, that instead of adenylyl cyclase, we are going to attach over here is the guanylyl cyclase. The enzyme that is going to activate is guanylyl cyclase if the NO or ANP binds to the G protein. The NO or ANP binds to the G protein, then guanylyl cyclase will be activated instead of this. Guanylyl cyclase is activated. Of course, the GTP will be converted into cyclic GMP, and it is the cyclic GMP which is going to activate the protein kinase. So that's why instead of protein kinase A, now I'll be writing as protein kinase G. Right? Again, the phosphorylation will occur, and whatever response needs to be happening there in the organ, that will take place. All right, that is about the cyclic GMP. It's kind of similar to that of the cyclic AMP. There are going to be some differences, but of course, that is not per se required for your exam. Now, coming on to the IP3-DAG, this pathway is a bit different. See over here, as soon as it is going to bind to the receptor, that is GPCR protein, of course, the GQ will be the protein, the type of the GPCR protein to which it is going to attach. Cyclic AMP or cyclic, you can say cyclic AMP only, it is going to attach to GS or GI, G stimulatory or G inhibitory protein. Alright. Now, G protein is activated. That will activate phospholipase C. Again, the enzyme will be activated first. That enzyme will break down the PIP2. That is phosphatidyl inositol diphosphate. Okay. So that will be converted into IP3 and DAG. Inositol triphosphate and diacylglycerol. So once that has been done, this IP3 will go towards the endoplasmic reticulum, or if it is a muscle, sarcoplasmic reticulum, and that will act on the specific receptor for the IP3, that is known as IP3 receptors. And as soon as the IP3 binds to the IP3 receptor, the calcium channels will open and the calcium will come out of the sarcoplasmic reticulum. Of course, if it is a muscle, it is going to cause contraction. So IP3 is responsible for calcium. Now this DAG, again, it is going to activate the protein kinase, right? And the protein kinase will be activated, and that is going to give the cell response. Again, protein kinase are going to do the phosphorylation. Okay. So please remember these pathway. Enzyme will be activated first, secondary messenger will be created, and then the protein kinase will be activated. Please remember the sequence. All right, let's move on to the hormones which are going to release by the posterior pituitary, that is oxytocin and ADH, that we are going to discuss first. And oxytocin and prolactin both have some role which is similar to each other. So that's why we are going to discuss that first. First thing, oxytocin is responsible for parturition reflex. That means during delivery, we saw that in the general physiology, as well as milk let down reflex. It is going to cause the contraction of the uterus during the delivery. It is going to cause the myoepithelial contraction of the breast during the lactation period. Now, in the males, it is going to help in the contraction of the vas deferens that will be responsible for sperm ejaculation. Now, coming on to the prolactin. Prolactin is going to be responsible. It is released by the anterior pituitary, but it has similar role, especially in the lactation. Both are required, so that's why I have written over here. Now, remember that the prolactin is released by the anterior pituitary lactotropes, but it is under the inhibitory control of the hypothalamus. Why? Because hypothalamus is going to release pituitary inhibiting factor. Pituitary inhibiting factor, what is it? It is none other than the dopamine. It is none other than the dopamine which is going to release or inhibit the release of this prolactin. Yes, during the lactation, when milk needs to be produced, at that time prolactin releasing factor will be released by the hypothalamus. In case if the pituitary stalk is cut, that means it is separated from the hypothalamus now. The pituitary is separated. All the anterior pituitary hormones, they are going to decrease. Why? Because they are under control of releasing hormone that is released from the hypothalamus. But if we talk in terms of the prolactin, it is going to be increased because generally it is under the negative control, which is gone after the cutting the stalk, Now, coming on to the lactation cycle, this has only asked in one of the FMG exam. So, I felt it is important to include that this time. So, growth of the breast is going to occur first. What they have asked is to cycle it up. That means sequence it up. So, first of all, of course, the mammogenesis is going to take place. If there is no growth of the breast, then there will be no milk production. That is going to occur. This mammogenesis is going to occur during the puberty, but mainly it is going to occur during the pregnancy. Then coming to the initiation of milk synthesis and secretion will start, that is known as lactogenesis. Please remember, this will start in the third trimester itself, a little bit, end of the third trimester. Okay, lactogenesis. It has two phases, 1 and 2. Then lactation or galactopoiesis, that means actually the lactation will start, the milk will be coming out of the breast whenever the baby wants it. Then regression of the breast during or after weaning, that is involution, will take place after once the mother stops the breastfeeding. Let's move on to the ADH now. ADH, please remember, it has 3 different receptors. What are the 3 different receptors? V1, V2, V3. V1 is also known as V1A and V3 is also known as V1B. Now, what is the role of V3? Please remember, it increases the ACTH secretion. That's all. That's all about the V3. Now, they will mainly ask you about the V1 and V2. So, you should know about it. What about the V1? We have already discussed that V1 is going to act via IP3-DHE. If it is acting via IP3-DHE, that means it is going to cause constriction. Why? Because it is going to ultimately increase the calcium. As soon as the calcium is increased, what is going to happen? It will do 2 things. What are the 2 things it is going to do? First of all, it will do the constriction of what? Constriction of afferent and efferent arteriole. Afferent and efferent arteriole, fine, because of which what is going to happen? It will be able to maintain the GFR. GFR regulation is going to take place because of this, right? What about V2? V2 is going to act through the cyclic AMP and it is going to increase the aquaporin 2 numbers. Aqua means water, por means, of course, the gateway for that, aquaporin 2, and that is going to increase the H2O reabsorption, that is water reabsorption. So please remember 2, 2, 2, that is V2 is going to increase aquaporin 2 and that is going to cause the more and more water reabsorption, especially in the kidney, CD and DCT. CD more than DCT, we can say. Alright, let's move on towards the HPO axis of the growth hormone. All the anterior pituitary hormones, they are going to follow this. They have specifically asked about the growth hormone. So please remember, if I talk about the growth hormone, there is one hormone which is getting released from the hypothalamus, which is going to cause, so see, growth hormone will be released from anterior pituitary, somatomammotrophes, right? Now, one hormone is inhibiting that, that means it must be GHIH, that is also known as somatostatin, and this B is somatomedin, or we can say it is nothing but GHRH, growth hormone releasing hormone, right? And what is released by the liver? When the growth hormone acts on the liver, the indirect effect will be occurred via IGF. Now, please remember, in the adult life, we do have IGF-1. In the fetal life, the fetus has IGF-2. It's vice versa. When we are born, we do have IGF-1. When we were fetus, at that time, we had IGF-2 for the skeletal muscle and other growth, right? So, please remember, this IGF-1 is going to do the, again, growth in the human being. Now, factors affecting growth hormone. What are the factors that are going to increase the growth hormone? Please remember, hypoglycemia. If you are, let's say, fasting, or the person is starving, so starvation, or for example, you are doing the exercise. right? In all these conditions, the hypoglycemia will be developed and the growth hormone will be increased. Protein meal, on the other hand, if you have the protein meal, that's why when you go to the gym, the people urge to have the protein meal. So proteins are going to have the amino acid, of course, it is made up of amino acid. That is also going to increase the growth hormone, psychological stress and pyrogens, and the hormones. What are the hormones? First, estrogen, androgen, and that's why we do have puberty. In the puberty, we do have growth spurt, right? Estrogen, androgen, and ADH also causes increase in growth hormone. There are some drugs such as alpha adrenergic agonist and dopamine agonist. So these agonists are also have the positive effect on the growth hormone release. So please remember, when the glucose is low, the growth hormone will be released and that will increase the glucose. But whenever the glucose is high, what will happen? The negative feedback will occur and that is going to inhibit the release of growth hormone. Please remember that. So growth hormone itself will give the negative feedback. When it is more, it is going to cause the decrease in the secretion of growth hormone. IGF-1 also gives the negative feedback to the anterior pituitary and cause inhibition for the release of growth hormone. REM sleep is going to decrease the growth hormone. On the other hand, NREM sleep is going to increase the growth hormone. Cortisol and somatostatin. Cortisol also decreases growth hormone. Somatostatin, the name itself telling you that is nothing but the GHIH inhibitory hormone, right? So itself telling you that growth hormone will be decreased by this. Now see over here, there are going to be some direct action and indirect action on the tissues. Direct actions are going to occur through the receptors of the growth hormone on the tissue directly, but the indirect effects are going to occur through the IGF and they should be in the balance. Why? You'll see that. Protein synthesis epiphyseal growth is same, whether it acts directly or indirectly. Growth hormone or IGF having the same effect. But see over here, the growth hormone has one extra effect, that is sodium retention, which will not be there if the growth hormone acts indirectly via IGF. And there are two opposite effects which are going to be there of the growth hormone and IGF. That is nothing but the lipolysis is done by the growth hormone as well as a decrease insulin sensitivity. You are decreasing the sensitivity, that means insulin will not be able to act on the tissue, right? Plus we are doing lipolysis, that means we are releasing more and more energy into the blood. What will happen? Diabetic-like symptom, that means hyperglycemia can take place if the growth hormone is high, excessively high in the blood, and that's why it is known as, growth hormone is known as diabetogenic hormone. The growth hormone is known as diabetogenic hormone. But please remember, in the normal healthy person, we have IGF-1 also, which is going to counterbalance this effects of the growth hormone. That is, it is going to have anti-lipolytic activity and insulin-like activity. See, its name is insulin-like growth factor. So, of course, it is going to do insulin-like activity. So, they balance each other. Now, coming on to the thyroid hormones, see over here. Thyroid, first of all, let's say that we do have follicular cells and parafollicular cells. What are the follicular cells? See, these are the big follicles. Assume that these are the big follicles. We're going to have cells in them, right? So these cells will be called as follicular cells. And in the periphery, we're going to have small parafollicular cells. The green ones are parafollicular cells, which are going to release the calcitonin. But remember that these follicular cells, these purple ones are follicular cells. The whole is the follicle. They actually just trap the, you can say, iodine, but the thyroid is actually formed in the colloid. So, the space between the follicular cell is known as colloid, and there the thyroid is actually formed. So, if I ask you how the trapping is going to occur, so see over here, assume that this is the blood vessel which is going along with this follicle. What will happen? If I zoom it in, it will look something like this. Okay, so assume that I'm zooming this part out and showing you over here. So this part will look something like this, that the blood vessel is going, right? And then we have these follicular cells, and over here, this must be the colloid. So I'll write it over here. This is the colloid. Now, first of all, we have to remember the sequence. So, how to remember? Again, I have mnemonic for our aid, that is topsir. What is topsir? Let's see. First of all, we need to trap the iodine because that is required for the thyroid formation. So, how to trap? Of course, the patient or the subject is going to take the iodine via the dietary, or you can say ways, right? So, iodine will come inside the cell via the NIS. What is NIS? That is nothing but the sodium iodide symporter. Of course, it is symporter, means it is the secondary active transport. With that, what will happen? That the sodium is going to come into the cell, and as soon as it will come into the cell, what will happen? We need to send it into the colloid. So, how we are going to send it? There will be a protein which is known as pendrin protein, which is going to give the iodine into the colloid, and instead of that, in exchange of that, it is going to take the chloride back. This chloride will keep on cycling there only because they are going to have the chloride channel also. We're not bothered about this chloride right now, but remember, this pendrin protein is also present in the ear. Okay, so if the pendrin protein is not working properly, if it is defective, the person will come to you with two complaints. First of all, hypothyroidism, because it is not able to trap the iodine, and second, it is going to come, that person is going to come with you with SNHL, that is sensory neural hearing loss, which is known as Pend-Red syndrome, right? Pend-Red syndrome. Please remember, pendrin protein is defective, Pend-Red syndrome will occur. Now, fine. If the trapping is done, now the iodine has come into the, we can say it has come into the colloid. Now, what we need to do, iodide has come. I have to convert that into iodine. How we can convert that? With the help of TPO. What is TPO? Thyroid peroxidase. This is the only enzyme which is going to be there. So, thyroid peroxidase. So, thyroid peroxidase is going to be there. So, that will combine these I minus, that is nothing but iodide molecules, and convert it into iodine. Now, there will be another protein which is going to be there, that is known as thyroglobulin. This thyroglobulin is the protein. That means it must be made up of different amino acid. One amino acid it is going to be there on it, that is nothing but the tyrosine. So, this benzene ring which is shown, that is nothing but the tyrosine. Now, if one iodine molecule binds to the tyrosine, it will be called as monoiodotyrosine, that is MIT. If, let's say, this was the tyrosine, and if two molecules are going to bind to the tyrosine, it will be called as diiodotyrosine. So, this process is known as binding or conjugation. Now, MIT and DIT is formed. I need to make T3 and T4. 2 are formed or 2 are formed. We have to make it 3. How we can make it 3? MIT is there, attach one DIT to it. It will become T3. If DIT is there, attach one more DI to it. It will become T4. Alright, that's how the coupling will be done. So, let's write it one by one. First of all, let's say T for trapping. So, please remember, the trapping will occur first from the blood vessel into the colloid with the help of, first of all, on the basolateral membrane, we do have NIS, that is nothing but the sodium iodide symporter. It is iodide symporter, right? And then on the apical membrane, we have pendrin protein. If it is defective, which syndrome will occur? Pend-Red syndrome will occur, right? Hypothyroidism plus SNHL, sensory neural hearing loss. Alright, so with that, we have trapped the iodine into the colloid. Once the iodine is trapped, what will happen? Of course, the oxidation will take place. Oxidation, that means we are going to take two I molecules, that is iodide plus iodide. With the help of TPO, we are going to convert that into iodine, right? Next, oxidation is done, then we are going to do the binding or conjugation, right? This is also known as organification. Different name, right? Organification. Now, in this organification, what will happen? Of course, we have this I2. What we are going to do is, we are going to attach the I2 on tyrosine molecule. Either we are going to attach one I2 or we are going to attach two I2s, right? So if we attach one iodine molecule to the tyrosine, that will form the monoiodotyrosine, or it will form diiodotyrosine. Then we will do the coupling. In the coupling, what we are going to do, and please remember, everywhere the TPO is going to help us out. That is the only one enzyme which is going to be present over there. In the coupling, what we are going to do, if the MIT is there, we will attach one DIT to it. And once the DIT is attached, it will become T3. And if the DIT is already there, we attach one more DIT to it, it will become T4. Now, we cannot call it as tyrosine anymore, because now two tyrosines will be coming together. Now, it will be called as triiodothyronine and tetraiodothyronine. Tetra is also known as thyroxine. Okay. Now,